so people may not be able to get up. So we'll start first session this morning. I would invite my good friend from Texas, Christian, as a chairperson, and Sai Kalyan from Hyderabad to conduct this contributory and very important session. We'll hand over to him.
Good morning, everyone. So we shall be starting this contributory session, and we request Dr. Adesh Srivastava to talk on sinonasal outcomes after transnasal surgery for pituitary adenomas.
So at the outset, I would like to thank the organizers for this opportunity and the chairpersons. We all know that transfenoidal surgery through the transnasal route has its own fair share of sinonasal morbidity. And these morbidities and complications have often been underreported, both by the patients as well as the clinicians. If you look at the literature comparing uninostril, binostril approaches, it's equivocal. You can find equal number of articles that support uninostril and that support binostril. This recent study from our Vellore group, led by Professor Vedantam Rajshekhar, has found that uninostril approach is associated with better post-operative life as compared to the binostril approach. Another recent meta-analysis and systematic review done by this Chinese group has also found similar results, where binostril group had more incidence of hyposmia as well as anosmia and a lower overall quality of sinonasal experience. So there are multiple such studies available in literature which support this, and we did an analysis of our own experience, which included 70 patients, and we used the ASK12 nasal inventory score rather than the SNOT because it is more specific to the sinonasal symptoms than to the generalized symptoms, and that is specifically for the anterior skull base surgery. And we found that for the sense of smell, the sense of taste, as well as the overall nasal experience, both for the short term as well as for the long term, the experience was better, the scores were better for patients going through uninostril approach as compared to binostril approach, and the results were significant statistically. So based on this study, our conclusion was uninostril should be preferred over the binostril approach, especially for pituitary adenomas, which account for more than 80 or 90% of our practice of our surgery through the transnasal corridor. And with this, we further refined our technique, and our current recommendation is stop using the nostril. Let's not go through the nostril, and let's go back to the corridor, which was used in the microscopic era, which is the transseptal approach. Do not invade the nasal mucosa. That is we recommend the use of the transseptal endoscopic approach, that is the TSE. We'll have a brief demonstration of this approach. In this case of a 57-year-old male having a pituitary adenoma, there is some amount of apoplexy, past apoplexy also that has happened. It's a NOS2 tumor. And as we can see, that once we begin with our nasal phase of surgery, once you enter inside, after you have blanched the mucosa, we can appreciate the nasal anatomy, start lateralizing the turbinates, identify the choana, the proposed site of the sphenopalatine artery and the sphenoid sinus, and then as anterior as possible at the mucocutaneous junction, just take one vertical split from top to bottom and reflect the nasoseptal flap laterally. This is similar to what we used to do with our microscopic approach. I mean, many of us have been doing it, but looking at it in this way would, I think, help preserve more of the nasal anatomy than what we usually do. So this bony septum is fractured. It can be taken out if it's too rugged, or if it can be just pushed, as in some cases of microscopic surgery we used to do, one can do that. I'll not talk about the Haddad flap. Now, this is for pituitary adenomas. Once you have reflected the nasoseptal flaps on both sides, you get a good corridor through which you can do your drilling and take out the keel of the vomer. Once the keel of the vomer has been removed and you expand your corridor, the scope can go further inside, and then one can easily identify all the structures and start with the drilling process. As you can see, through this septal corridor, we are able to push in two instruments along with the scope. One can easily put in a suction, a drill, and it's with experience, it's quite easily possible, especially for pituitary adenomas. After that, the surgery follows the routine way as we do it, durotomy, taking out the tumor. And once the tumor is completely taken out, a multi-layered closure is done to the same corridor. And finally, at the end of it, just pushing the flap back to its position and the surgery is done. So this is the transseptal approach. This is the post-operative Devon scan showing complete removal of the tumor. And a 3 weeks DNE which has been done. This is the incision which we had taken, vertical incision, as one can appreciate in this. So direct nasal examination showing the septum to be intact. The turbinates are almost as pristine as they were preoperatively. This is from the right side. From the left side, if we go in again, one can appreciate that the septum is totally preserved. The turbinates are preserved. So basically, you have not violated any part of the nasal mucosa. This is a case of a NOS2 pituitary macroadenoma in a 52-year-old male. Again, the same concept. I think I'll skip this video for the sake of time. This is the post-operative day 1 contrast-enhanced MRI showing good removal. And this is a delayed DNE. I think it is done at 3 weeks, which shows that the nasal septum is intact mostly. A small part of the septum, posterior superior part, has a hole. But if we see the site where the sphenopalatine artery would come, which can be used as a nasoseptal flaps lifeline later on in a recurrence case or for any other surgery for this patient, can be used. Now, there are multiple cases. This is a case of a 57-year-old male with a NOS2 tumor. Again, a transseptal approach, a GH adenoma through transseptal approach, another non-functional pituitary adenoma through transseptal approach, another NOS2 tumor through a transseptal approach. So basically, more than 90% of pituitary tumors, the pituitary adenomas, can come through this transseptal approach. Now, how does it differ from the microscopic approach is that when you have your microscope, the visualization is from the outside. So one need to, the two flaps of the two nasoseptal flaps had to be separated using a speculum. But with the endoscope, you don't need a speculum because your scope goes inside and the tip of the scope is beyond the level of the sphenoid ostia. That's where the corridor enhances, the corridor increases in size. It's like you're going through the tunnel and then opening into a funnel. So that was the part which was important for the patients as regards as morbidity is concerned. What it is in there for the surgeons? Well, it matters in cases of recurrence, which are bound to happen because of the number of cases that are being done these days. And one may be faced with the situation, if we continue doing the way it has been done, we're faced with a situation where you have nothing to repair in a recurrence, and this is what happens, and ultimately requiring a craniotomy and repair of the defect. Compare this with this post-operative case where a CSF leak happened, and because this transseptal approach was used, the leak could easily be repaired with the available flap. So our experience over the last 8 years have been of about 187 cases done uninostrally, which is now more of transseptal approach. We consciously see to it that we don't enter into the nasal cavity. What we have found that it has better nasal quality in the post-operative period. It is more comfortable, easier for the neurosurgeon to do it, having similar or gross rates of total resection compared to the binostril, with no significant difference in hormonal remission, pituitary insufficiency, or diabetes insipidus. And in fact, one can possibly convert it into a binostril approach as and when it is required. Thank you.
Very nice presentation. Any questions from the audience?
Adesh, very Nicely presented. This was one question I asked many years ago when
Sir.
this extended endonasal came, because we kept in endonasal, we open a lot of things. I asked an ENT surgeon from other side, don't you think there's a lot of morbidity in the nose? He said, no, there's not much morbidity. This is something which we are not talking. If we give enough importance to this, then our kind of choice of patients, because the nasal morbidity is not seen, whereas your flap morbidity is seen on the surface.
Correct.
So that is a comment. Second question is, you said uni-nostril, so you don't raise the Haddad flap. What you showed this, you went through this is exactly what I also do, except that I take the flap out and keep, so it becomes like half in half out.
Okay.
So you don't, so in these cases, most of the times you don't raise the Haddad
We don't
flap.
raise the
You use
Haddad
a free
flap, sir. No, sir.
The only challenge I found a difficulty is when the bone is not in the middle, when you have two flappy septa.
Suction
every
will.
time you put suction, it keeps on
Yes.
coming and closing.
Yes.
So that is a, if the mucosa is not very thin, you can manage. But if it's thin, it will continuously irritate you as you keep going and coming, because the gap closes. Then then for that I'm forced to, I just cut the lower half of the flap and
Yes.
move it so that it doesn't keep flapping, and keep the upper half still intact, and use it as Haddad if you want, or if you don't want Haddad, just put back and come out.
Yeah. So
So
for this thing,
can you tell the challenges you face in this?
yeah. So for this thing, what we do, we take the incision lower down towards the floor. So it opens a broader area so that air can enter it in and your flap does not collapse. For the first part, what you said is the nasal morbidity. We as neurosurgeons are overwhelmed by the tumor and the pathology, and we, even if the patient says, Doctor Sahab, there is something coming out, I'm not feeling this thing, we all shun the patients. That's what happens. Yeah.
Well, we welcome to the podium Dr. Arivadzagan with the CSF rhinorrhea post-treatment in prolactinoma, incidence and management options. Thank you for being here.
Good morning, everyone. So I'm going to talk about a topic which is not very common, not often seen, but something which we need to remember. Continuing from the post-op rhinorrhea that Dr. Adesh talked about, we all know that we are treating prolactinoma with medical management. I think even that is being contested now, whether prolactinoma is only a medical disease or early surgery is useful. But when we give medical treatment to this prolactinoma, sometimes you end up having a CSF rhinorrhea. We know these are the common cause of CSF rhinorrhea, which we deal with on a daily basis. But this is one of the uncommon cause of CSF rhinorrhea, where a patient with a macroprolactinoma on Cabergoline therapy presents to you with a spontaneous CSF leak. Is it so rare? But when apparently it is not. If you look at the data, though this has to be taken with a pinch of salt, because this is hospital-specific curated data where you may have a higher number. If you look at the data, the numbers are more, and the percentage-wise, if you look at this series, they said out of 30 patients, they had 4 patients who developed CSF rhinorrhea. Incidence is as high as 13%. And in this paper by Suleiman et al., they said the overall incidence in macroprolactinoma is 8.7%. If that is so, we should be seeing a lot of patients with CSF rhinorrhea. However, when does this CSF rhinorrhea occur? It happens usually in secreting tumors, most common being prolactinoma on dopamine agonist therapy. Why? Possibly because these are giant tumors which erode through the bone, causing a defect, and once you give Cabergoline therapy, it shrinks down and causes a fistula because the tumor has already eroded the dura and the skull base. Are there any predisposing factors? This paper in 2007 analyzed all the factors and found men have a higher chance of having CSF rhinorrhea. The tumors which had a dopamine agonist resistance, which required long-term therapy, has higher incidence. And of course, they also looked at whether the initial prolactin level can predict rhinorrhea, but that's a mixed bag. Some papers have shown it is not useful, and whereas in some these papers have shown this determinacy leakage showed initial high prolactin levels could be a cause for CSF rhinorrhea in these tumors. These are all the papers published last year where they've analyzed the same causes, which means that this is a current problem. It's not something which is done and dusted. And so what are the factors which could predispose? Meaning, when you see a patient with macroplatinoma, when you start medical management, you should be aware that this problem can occur and educate the patient that you can have a CSF rhinorrhea. If so, you need to come back. You cannot rule out that surgery is not required in your case. So sphenoid sinus invasion, a paper, one Lacey et al. Found it could be significant, whereas in the other paper that I showed you, it was not significant. But what is not significant is tumor size or volume. Just because a tumor is small doesn't mean it will not result in CSF leak. And the initial prolactin level, it could be very high, but may not still have, but even a lower. So these are things which are red herrings. You cannot just go by the tumor size or the volume and the initial prolactin level and say that no, you are not having a risk of CSF. Any patient with large tumor, any patient with prolactinoma, when we start on medical therapy, it is our duty to educate them that, yes, you undergo medical therapy, but if you have this problem, come back to us. So we analyzed our patients whom we treated over the last 5 years, 7 of them, all of them are prolactinoma, and 6 patients developed CSF leak after starting therapy. 1 patient presented with CSF rhinorrhea and tumor before starting therapy. That means the tumor is already eroded and resulted in CSF leak. This is less common because most of the time the tumor acts as a plug, and once you give the therapy, it shrinks down. So all of them are treated with cabergoline. Like you can see, the mean serum prolactin level is 10,000, no meningitis at presentation, and this is how we treated. Out of 6 underwent endoscopic endoscopic or microscopic, and bifrontal craniotomy for 1 cribriform defect. 3 had recurrence after surgery, required again endoscopic repair, and 1 required TP shunt. So, and in all the patients, finally we could stop the CSF rhinorrhea, and the key point is cabergoline should be continued. So this is something, once patient develop CSF rhinorrhea, should we stop the therapy? No. We should continue this therapy. This is just a case example, large giant prolactinoma presenting with CSF rhinorrhea after therapy. You can see that, you can see that CSF is welling out in the nasal cavity. You open the, here, because of the tumor, the cella will be destroyed, dura will be torn. This is how it will look like. You will see the CSF welling down from a small crevice in the cella floor through the dural defect. You need to repair it. You need to open the dura if required so that you can remove a bit of the tumor, make a proper opening, and then repair as how we usually do. So standard repair, I'm not going to show that. This is how I think Adesh was showing. This is a free flap. We have gone through the transeptal effect. So this is post-op. After 6 months, patient continues to be on cabergoline therapy. CSF rhinorrhea has stopped, and that you can see the size of the tumor, which has significantly shrunk. Here the surgery was not to decompress the tumor, but was to repair the floor as well as to stop the CSF leak. This is another patient after 8 months of cabergoline therapy. You can see the tumor is bulging down into the cella and having CSF leak. I think I'll skip this video. So what are the management issues? Should we continue dopamine agonist or stop? So the data and literature says you need to continue. Stopping the drug may result in temporary cessation, but that's not the end of the story. You need to restart again and there will be leak. So surgical repair is indicated in most cases because the numbers are small. One cannot say what will be the exact success rates. But we need to remember one surgery may not be sufficient. You may need to reoperate. Leak may not stop. You may need to have a shunt as a second option. So this was a meta-analysis which analyzed 52 patients where they had 15 spontaneous leaks and 38 of them had leaks after medical therapy. You can see the most common is prolactinoma. However, the other functioning tumors are not kind of immune. They also can develop. Any tumor which causes erosion of the floor and then you give medical therapy can result in CSF rhinorrhea. Second point, another point you have to remember is that even after first surgery, there is a very high chance of CSF leak again because we are not repairing a surgically created CSF fistula. Here, the tumor has caused destruction across the cellular floor, including the lateral wall, sometimes anteriorly to the tuberculum cella. So initial surgical repair itself can be difficult. You need to identify all the defects and cover everything. So if not, there is a high chance of leak requiring resurgery. So to summarize, the incidence as per literature is as high as 8%. However, most of us who are dealing with pituitary adenoma do not see that high numbers. It can occur almost in all functional tumors, but most commonly in prolactinomas. Timings can vary from days to years. We have had patients coming after 3 years or 5 years of therapy. So you cannot say that patient did not have leaks, so 5 months, so it will not happen. And the initial prolactin levels don't seem to influence the onset of leak. And most often it is due to sphenoid erosion. And the medical therapy should be continued along with surgical management. Conservative management can be tried for a short period, but in most cases it gets converted into a surgical need. So one need to be cautious about just starting Diamox or stopping medicine and wait. You may pass over the problem temporarily, but it will come back again. That's something you need to remember. And many surgeries may be required, and patient counseling and vigilance is the important thing. Thank you.
Any questions from the audience? I have a quick one.
Important for us to make it as a single cavity. Otherwise, you repair a small hole and come, it starts. So we open the dura, make it as a single durotomy, and remove the tumor that is there on in your field of view for biopsy and confirmation, and can repair and come out. Yes, yes. If you have a lot of tumor in the cellular, supracellular, that can be removed as part of the surgery. But what I mean is you don't need to chase, in prolactinoma, you don't need to chase the cavernous sinus component, all those things for the sake of tumor decomposition. Thank you.
The next speaker is Dr. Kodeswaran, and he's going to talk about the Kilpak keyhole craniotomy, evacuation of SDH, and endoscopic inner membranectomy.
Good morning, everyone. First of all, I would like to thank Dr. Bansal and NEUROENDCON team for this opportunity. The topic is Kilpak keyhole craniotomy and endoscopic evacuation of chronic subdural hematoma. This is a procedure we developed in the past 2 years. So just I'm going to talk about that. This is the patient position before we start the procedure. We used to fix the head to do the navigation registration. We'll register the navigation and we'll mark the posteriormost end of the clot to create this craniotomy. These are the requirements: 0 degree 4 mm scope with a sheath and the basic normal instruments like 2 mm upcut and disc punch and suction device with the video camera and recording system. And also we use irrigation pump. This is the marking we used to mark along the question mark. Even if we require to convert it as open, we used to, but most of the cases we don't require any conversion. This is the illustration of this keyhole craniotomy. We used to open the flap, periosteum is seen. Periosteum is elevated and the bone was exposed. We'll make a pilot burr hole to make the endoscope to seat in that part. So we used to call this as endoscope landing zone. Then we'll make a small craniotomy of 2 to 2.5 centimeter size at the lower end of pilot hole. So it's appearing like a keyhole, so we used to call this as keyhole craniotomy. This is the illustration to demonstrate the keyhole craniotomy. Then we start beveling. Actually, the pilot burr hole part we used to bevel in the outer table, and also we used to bevel the inner table of that craniotomy part. So that will allow the endoscope to navigate throughout the space. Then the craniotomy is done. So this is how we used to bevel the craniotomy part. The pilot burr hole, which was beveled in the outer table, and the inner table was beveled in the craniotomy part. We used to call this E landing, the endoscope landing zone, and the other part is endoscope flowing zone. Then we open the dura, then the liquid clot will come out. Then we insert the 0 degree 4 mm scope with irrigation pump used to irrigate and evacuate the clot. Whenever there is a bridging vein, used to coagulate if necessary. Most of them we used to avoid it. So the advantages of this procedure is complete visualization of the cranial cavity, and also the removal of inner membrane will allow expansion of the brain. We never encountered recurrence using this technique. This is how the endoscope flow from the top to bottom, and you can visualize the complete frontal pole to posteriormost portion. Once you go in, you will see the inner membrane. We'll make a small nick in that. Then we slowly start removing the inner membrane to allow the brain to expand. This is how the inner membranectomy was done. Then at the end, we used to keep a infant feeding tube to irrigate continuously. This is how the wound was closed. So the advantage is complete visualization of the cranial cavity, and also the removal of inner membrane will allow the brain to expand. There was no significant recurrence. Learning curve is also shorter. It's also a stepping stone for neuroendoscopic surgery. This is our pilot series published in 2024 in World Neurosurgery. This is the recent article we published in Neurology India as a video article. That was the illustration was in the cover page of Neurology India. Yes, the 2 days back, JNS Case Lessons published a similar series of 13 patients. So total number of cases we have done is 52. Our RCT completed with 30 patients with both arms. It's in the review process. No recurrence was encountered. All the procedures were done by me as single surgeon. One patient deteriorated due to other comorbidities. This is our team. I want to show a video. It's a chronic subdural hematoma patient with significant navigation was done. Periosteum elevated.
The video is not being displayed.
Multiple packets of subdural hematoma with midline shift and mass effect. Skin incision made, flap was elevated. Periosteum was elevated. Violet burr hole was made to develop the E landing zone. Small craniotomy was done. The bone flap was elevated. Beveling was started. As I said, inner table of the craniotomy part and outer table of the landing zone. Then dura was open. Subdural hematoma was evacuated. Now using irrigation and suction, the remaining clot was evacuated. Now we can go up to the frontal pole to see the complete cranial cavity. Now there was a nick made by a knife to open the packets inside. Multiple packets are open. Using a disc punch, we used to just elevate the inner membrane. And slowly start removing the inner membrane. So used to irrigate and remove part and part of the inner membrane. You should avoid traction. Now we reach the frontal pole. So multiple packets are opened. So brain started expanding. We used to place a drain tube at the frontal pole, and also in the continuous irrigation was started through the tube, because otherwise it will create pneumocephalus. So we used to do repeat scan on day 1, 3, 5 and 7 and after 1 month. This is the post-op. Midline shift is corrected. This is one of patient done bilateral subdural hematoma. Post-op. Post-op day 3. Post-op day 5. Second case, bilateral. Third patient is a complex one with intracerebral hematoma also. Membranectomy and intracerebral hematoma also evacuated. So the conclusion, it's a simple basic procedure for endoscopy. It will give expansion of the brain and also significant recurrence was reduced. Thank you all for your attention.
Thank you, sir. It was a nice presentation. Any questions from the audience?
Yes, Jayesh? It's a gel foam. Gel foam. Just gel. Gel foam and we'll stitch with the periostem. No, we won't replace. No, actually the problem is pneumocephalus. So we encountered pneumocephalus in few cases. So what we used to do, we continuously irrigate the cavity with the infant feeding tube. And we used to keep the tube for 1 or 2 days with the drain. So automatically the brain will expand, the CSF starts secreting. The pneumocephalus is, we never replaced.
Sir, I have a question. In some cases, the inner membrane is so adherent to the brain that, in some cases, the inner membrane is so adherent to the brain at times. In that cases, you deliberately leave it behind? Or
Just inject the water in between brain and the inner membrane. The inner membrane slowly will elevate from the brain surface. So you can start removing the inner membrane.
Thank you, sir.
No, we are inside the dura. So we are not crown. No, we never attempted that, but it is inside. We are doing only inside the dura. We are not going outside the dura. Yes, yes. From the origin. We have to block from the
You have to be
origin.
more anterior for that.
You can ligate it. No, we don't have much recurrence in this also. So we can replace, but yes, we modified it. Yes, 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 yes. Correct, correct. Yes. No, it's going inside the skull. It's a very small defect. Nothing was. Yeah, we can replace. Yes. Correct, correct. We can do that. Yes, yes.
We invite to the podium Dr. Siva Prasad, predictors of complications and recurrence after endoscopic repair of post-traumatic CSF rhinorrhea.
Good morning. Today, I'm presenting about a predictor. Good morning all. Today my presentation is on predictors of complications and recurrences after endoscopic repair of post-traumatic CSF rhinorrhea. And CSF rhinorrhea, it is a sentinel sign of basal skull breach, which is a pathway for ascending meningitis also. Traumatic CSF leaks are around 1 to 3% of all head injuries, and spontaneous closure is seen in less than 50% of cases after 1 week. And we did a study to early and precise repair reduce recurrence and infective morbidity, and literature lacks a clear prognostic indicators in purely traumatic cohorts. And our aim to identify and quantify the prognostic indicators that influence the success of endoscopic repair in post-traumatic CSF rhinorrhea. And we are objective to determine the independent clinical, radiological and intraoperative predictors of surgical success and complications using advanced statistical analysis, and to translate these findings into endoscopic success score to optimize surgical planning in traumatic CSF leak management. We did it is a retrospective observational study. We did 38 consecutive patients with post-traumatic CSF repair undergoing endoscopic endonasal repair was taken, and we have it was operated standard endoscopic endonasal approach with uni or multi-layer closure and done by a single surgeon. And this is the CSF repair. We raised the Hadad flap, and we reached the defect. Defect, we have seen the defect, and the edges of the bone around the defect was clear, and the defect is plugged with seen the defect, and it was plugged with a fat graft followed by fascia augmented with the tissue, and then we placed the Hadad flap there. And demographics, and average mean age of our study is 37.5%, with the range from 25 to 52 years, with male 27 and female 11%, and with other comorbidities. And road traffic accidents were 34 patients, and fall from height is in 4 patients. And the complications, is seen in 4 patients in 10.5%, and post-operative meningitis is seen in 3 patients, and hyponatremia in 2 patients, and orbital ecchymosis or periorbital edema is seen in 1, and edema, a delayed epipistasis is seen in 1 patient, and persistent CSF pressure is seen in pressure symptoms are seen in 3 patients, and at least 1 complication is seen in 8 patients with 0 morbidity. And the recurrence rate, we defined early recurrence as with CSF rhinorrhea within 30 days post-operatively, and delayed recurrence 30 days to 6 months post-op follow-up. And early recurrence is seen in two patients, and delayed recurrence is seen in 1, and total of 3. And early recurrences, 1 managed resolved with lumbar drainage, 1 required revision surgery, and a delayed surgery revision was performed in the 1 patient. And the age as a predictor factors, and less than 30 years is 9 patients, and 30 to 49 age in 16 patients and 13 patients. And the complication rate increases significantly with age, with none occurred in less than with age less than 30 years, while nearly half of those more than 50 years developed issues with such as SIDH, meningitis or anosmia maybe due to vascular fragility and slow healing. Recurrence rose stepwise with age. Gender as a predictive factor, female patients have a higher complication rate than males, but not statistically significant. And preoperative meningitis, which is present in 5 patients and absent in 37 patients, and patients with active or recent meningitis has markedly higher complication rate and recurrence rate, likely due to impaired healing. And aggressive infection control before surgery is essential to optimize outcomes. And the duration of the leak, acute less than 7 days is seen in 14 patients, and subacute cases in 17, and chronic in 7 patients. Longer leak duration of more than 30 days was linked to significantly higher complication, and the recurrence rate likely due to persistent CSF inflammation, dural fibrosis, and anatomical or CSF dynamic changes. So early referral and timely surgery are the key to reduce these risks. And the laterality of the leak, whether unilateral versus bilateral. In our patients, unilateral leak is seen in 31 patients, and bilateral or multifocal in 7 patients. Bilateral or multifocal leaks have significant higher complication rate, with significance and higher recurrence rate. And the defect localization and anterior, middle, and posterior. Anterior is when it is located in cubriform or ethmoid roof, and middle in sphenoid sinus and planum sphenoidal, and posterior clavus or lateral recess of leak. And posterior skull-based defects have a higher rate of complication rate with significance, and all recurrence occurred in middle or posterior locations, with posterior defects at greater risk. Defect size. Larger defects of more than 10 mm are associated with a significant higher complication rate, and these defects are also shows a significant increase in recurrence rate, likely reflecting higher pressure leaks and bone erosion. And the number of defects, single defect is seen in 32 patients and multiple in 6 patients. Patients with multiple radiologically identified defects have significant higher complication and recurrences, reflecting extended bone damage. And the defect morphology, defect margin type. If patients with irregular morphology have significant higher complication rate, and all recurrence cases. And the type of graft, autologous graft versus synthetic graft. Among 38 patients, autologous grafts is done in 68.4 patients have low complication and recurrence rate than synthetic rate, though not statistically significant. And closure technique, multi-layer technique had a markedly lower complication and recurrence rate than single-layer closure, and a statistically significant difference. Lumbar drain was used in only 28.9% patients with a low complication and recurrence rate, and then no drain cases. And intraoperative visualization, we used endoscopy with navigation and conventional endoscopy. 15 patients underwent image-guided endoscopy. Image-guided guidance reduced the complication rate and completed elimination recurrence in cases. Concluding, we systematically reviewed all the significant predictors from our cohort, and we assigned the weight point based on the statistical significance and clinical impact on outcomes. And we proposed a scoring framework with clinical parameters of age more than 50 years, preoperative meningitis, leak duration, and bilateral or multiple side defects, and radiological parameters, defect localization, defect size, and irregular defect margins, and surgical single-layer closure plan, and synthetic graft alone used, and no image guidance used. And interpretation of the score, 0 to 3, which has low risk of CS, low risk, and 4 to 7 moderate risk of success, and 8 to 7 high risk, and 12 to 14 score was very high risk. And this ROC score, ESS demonstrated excellent predictive accuracy with the AUC of 0.83 for complications and 0.90 for recurrences. Concluding, significant predictors of complications and recurrences were found across clinical, radiological, and surgical factors. Early surgery, multiple layer closure, autologous grafts, and accurate defect localization improved outcomes, and posterior site irregular margins and larger defects and preoperative meningitis were with higher risk patients. Limitations is a very small sample of 38, and limits generalizability and multivariable power, and no longer follow-up times. Thank you.
Questions from the audience? Well, thank you for your talk. Have you found any difference with the cribiform ones to be different from the other sites? Noticed any difference with the cribiform defect?
No difference.
We invite to the podium Dr. C. Scoring pediatric patients with obstructive hydro.
Good morning, everyone. I am Dr. Meghna Singh Saigal. I am resident neurosurgery in NIMS Hospital. I'll be presenting external validation of endoscopic third ventriculostomy success score in pediatric patients with obstructive hydrocephalus. So, hydrocephalus is one of the most common surgical conditions in pediatric population. Obstructive or non-communicating hydrocephalus commonly arises due to causes like aqueductal stenosis, tumors, infections, or hemorrhage. VP shunt is the traditional treatment, but it is associated with a lot of complications like infection or blockage or revision surgeries. So ETV has emerged as a preferred treatment option to restore the CSF flow, and it is in minimally invasive nature, and avoidance for need of an exogenous material implanted in the body makes it more efficient. The ETV success score predicts a surgical outcome based on 3 indicators. One is age, etiology, and any prior shunt history. It offers a scoring range of 0 to 90, with higher scores indicating a greater probability of success outcomes. So, external validation of ETVSS can enhance clinical decision making by providing a reliable data and determines the suitability of ETV for pediatric patients. So, this is the score which was first practiced by Dr. Kulkarni in 2009. The score ranges from 0 to 50 with various age groups in pediatric population, with the most common etiologies encountered being post-infectious, IVH, myelomeningocele, aqueductal stenosis, or other causes which lead to an obstructive hydrocephalus. And they also include any history of any previous shunts. So the aim of this study was to externally validate the endoscopic third ventriculostomy success score in patients with hydrocephalus. Our objective was to compare this score in different pediatric age group and to determine and document the outcomes in different age groups as pre and post-operative success. So this study is a prospective observational study which was conducted in Department of Neurosurgery in NIMS Hospital. The duration of the study was 18 months. It was conducted from April 2024 till October 2025. So we considered pediatric population up till the age of 18 with obstructive hydrocephalus, and any communicating hydrocephalus or prior failed ETV history or active infections were excluded. Sampling technique was convenient. Sampling technique, we considered 65 patients for this study, and the key parameters were we validated the ETVSS in this, and we considered their surgical outcomes from the preoperative success score at 6 months and any radiological improvement or complications which they showed. So this was the age group which we encountered in our study population. So maximum were from 6 months to 1 year, and 1 year to 10 year of age group. We had maximum number of patients from that age group, and more were male population. Then the maximum etiology causing the obstructive hydrocephalus which we came across was aqueductal stenosis, and the next common was any brain tumors in the pediatric population. Now, mostly the patients presented to us were not having any previous shunt history. Similarly, the most common clinical presentation in such patients were headache and vomiting, which was followed by macrocephaly, and rest were the other symptoms which were the patients showed were seizures or any altered sensorium with gait disturbances or any developmental delays. So, preoperative ETV success score in approximately 32 patients, which is the maximum chunk, was somewhere 41 to 60, which is moderate amount. So we considered the follow-up as 7th day, on 7th day, 21st day, and 6 months. So on 7th day, there were improvement in almost 44 patients. On 15 patients showed no difference, whereas 6 patients deteriorated on the first follow-up. Then 21st day post-op follow-up, like previously discussed, there were 44 patients who improved, which decreased down to 40 patients ratio, and at 6 months that sustained to 39. So the association, if we consider the association with the age category, maximum number of success which was shown was at the age of 6 months to 1 year. Similarly, aqueductal stenosis was found to have the maximum success rate in this study. Overall, ETV success rate was, out of 65 patients, approximately 40 patients had success stories, whereas 25 patients came with failure of the ETV where shunt was required. So the present study demonstrated an overall ETV success rate of approximately 61.5% at day 21 and 60% at 6 months, which suggests that ETV not only predicts the short-term outcome but also long-term outcome as well. Age-wise analysis showed better outcomes in elder children with consistently with aqueductal stenosis being the most common etiology to show better outcomes, while post-infectious cases had poor outcomes in ETVS. Previous shunt surgeries did not significantly influence the study outcome at 6 months, which confirms the sustained outcomes. Limitations of the study was that it wasn't blinded, and the follow-up period was considered only for 6 months, which it can be extended up to 1 year or 2 years. Also, one of the critical research gaps was the limitation of available data application for ETVSS in pediatric population. So, to conclude, I would say the present study demonstrated that ETV is a safe, effective treatment in pediatric obstructive hydrocephalus with an overall success rate of 60% at 6 months. Higher success is observed in elder children with aqueductal stenosis, and post-infectious etiology showed poor outcomes. ETVSS showed a positive trend in outcomes with higher scores, but the only thing is it lacked statistical significance, indicating that it should be a supportive tool rather than a definitive predictor. Previous shunt history did not play any influence on the ETV's success, suggesting that it remains a viable option both in primary as well as previously shunted patients. Early successful outcomes were largely sustained at 6 months, confirming long-term reliability can be practiced for this procedure. Thank you.
Thank you, Dr. Meghna. Any questions from the audience? Yeah, I have a question. In your study, in the study, there were 25 patients who came back with a ETV failure. And among that 25, what was the etiology preoperatively? The commonest etiology?
So
in that
the most
25.
common etiology which we came across generally was also aqueductal stenosis.
And even in the 25
follow-up patients who improved were also from that particular unit.
Okay, thank you.
Thank you.
So we request next speaker, Dr. Prabhakar Kumar Singh, and he's going to talk about the assessment of outcomes of endoscopic discectomy for lumbar disc herniation, a prospective observational study.
Good morning, everyone. This is my topic for the today, assessment of outcomes of endoscopic discectomy for lumbar disc herniation. Lumbar disc herniation is a very common issue leading to lumbar radiculopathy, which is further causes pain and disability. Surgery is indicated after a trial of conservative management of 4 to 8 weeks. And if there are any red flags like cardiac syndrome or any progressive deficit, we need to go for the surgery earlier. The endoscopic discectomy is a minimally invasive option, relies on the targeted decompression, and has an added advantage of minimal invasiveness. This allows the faster recovery. The aim of this study was to evaluate the functional outcome of endoscopic discectomy in the management of lumbar disc herniation. The primary objective was to assess the pain, using the VAS score for back and leg separately at the time of discharge and after 3 months post-operatively in patients of LDH undergoing disectomy endoscopically. The secondary objective is to analyze the incision length, amount of blood loss, and muscle damage in patients undergoing the endoscopic disectomy. This is a prospective observational study including 30 patients which have been diagnosed with lumbar disc herniation and were operated by endoscopic disectomy. Pre- and post-operative clinical as well as the radiological data was analyzed along with the intra-op findings. Primary outcome evaluation was done using the VAS score for leg and back pain separately. So the total patients were 30 and the mean age is 40.3 years, and this denotes that the predominantly middle-aged adults are affected by this lumbar disc herniation. The sex distribution was equal in both males and females in this study. The clinical features mostly associated with these patients were having a low back pain with radiation to lower limbs, numbness, paresthesia, bladder ball dysfunction, or weakness, either toe drop or foot drops. The surgeries performed in the study was transforaminal endoscopic disectomy. Only one case was performed. Interlaminar endoscopic disectomy via the standard endoscopic system was performed in the majority of cases, that is 25, and mostly the level was L4, L5. Also, we performed interlaminar endoscopic disectomy via UBE along with MIS TELF for 4 cases, and all the 4 cases were at the level of L4, L5. So this is the image showing the removed disc, and in the right hand side we can see that the incision length is well marked and the almost around 1.5 centimeter. In the below we can see that 2-level discectomy was performed in this case via the Destando method, and in this case the incision length was slightly on the longer side. It was around 1.8 centimeter. And this is the marking showing for the UBE, and on the right hand side we can see the docking is also performed here. And after performing the discectomy, the post-op scar has been shown below, and on the right side the MIS TELF is also demonstrated. So now we'll see a video demonstrating the UBE. This was performed by our consultants, Dr. Saraj Kumar Singh and Dr. Anand Kumar Das sir. Now we can see that the docking has been done, and now we can see that we are proceeding towards the removal of the soft tissue using a RFA probe. And following the soft tissue removal, we will go for the removal of the bone fragments, and laminotomy is done using the diamond drill. Further, we can see that the ligamentum flappum has been removed using Kerrison punch. And after that, we perform the retraction of the root, and then we can see that a disc has been delivered. And yeah, we can see that disc has been delivered. So this is the comparison of a pre and post-op scans of MRI showing a T2 weighted axial images. On the left hand side we can see that the central to paracentral disc herniation, which has been properly removed, and there is some kind of edema there in the post-op scan. So the complications in this study was having a dural tear intraoperatively for only a single case. In this case, we had to convert to the open method. No infections were noted postoperatively in this study, and almost 10% of the cases, like that is 3 cases out of 30, have been reoperated for various reasons, out of which there is one case of recurrence, which had occurred after a period of 2.5 months. So coming to the results, we can see that the mean score of back pain was 6.83 preoperatively, which has been reduced to 3.20 just after the post-op period before discharge, and after a period of 3 months, we can see that has further reduced to 1.35 plus minus 0.63. For the leg pain, we can see that there is a higher side of improvement, that is 7.1 to 2.77 and 0.73 after a period of 3 months. All these were highly statistically significant, and the p-value is less than 0.01. The mean intraoperative blood loss for this study, in this study, was 92.1 ml, and the muscle damage, which has been graded using a tool that is British Athletic Muscle Injuries Classification, in which the majority of the injury was classified under the grade of 1 and 2, which signifies the minimal injury, and higher grade, that is 3 or 4, none has been reported. The mean initial length in this study was found to be 1.63 plus minus 0.23 centimeter. Please note that we have excluded the converted open case, which had a longer incision of 14 centimeter. So this is the British Athletic Muscle Injuries Classification, which has been discussed before. As we can see that grade of 1 is given if the total edema seen on the stir images is less than 5 centimeter. And if it is around 5 to 15 centimeter, it has been given a grade of 2. And further grades like grade 3 and grade 4 are for the muscle tear. So in my discussion part, it is highly efficacious, showing a significant improvement, and both early and sustained benefits have been noted, and the more improvement has been seen in the radicular leg pain, obviously because the nerve root compression was relieved, and only one case of recurrence is noted. So comparing with the literature, the dural tear rate is almost comparable to the previous studies done by Ranjan and lab, that is 0.67%, and the reoperation rates are also falls within the reported literature, that is 10%. So the study is highlighting the advantages of the minimal invasiveness, that is less blood loss, smaller incision, faster recovery, and absence of any post-op infection, as well as there is a regional significance that probably this is the first study done in the Eastern India from Bihar, and the outcomes are comparable to the global literature despite the environmental risks. The limitations for this study were that it's only having 30 sample size, and only a single center design was there, and thus the generalizability is compromised here, and a short-term follow-up only of 3 months has been a limitation here, because there are some patients who are coming after this also, and a lack of control or comparison with the open group or with other methods have been missing. So concluding this, the endoscopic discectomy demonstrates a significant pain reduction, low complication rates, acceptable reoperation rates, and thus the study supports the wider adoption of this minimally invasive spine surgeries. These are my consultants, Dr. Saroj Kumar Singh, sir, Additional Professor in Nursery, and Dr. Anand Kumar Das, sir, Assistant Professor in Nursery in AIMS Patna. Thank you.
All right, we will try and maybe take questions at the end. If there is time, we're running about half an hour late. So Dr. Watanabe is going to come up and talk to us about minimal invasive.
We can take one question. Amit Sinha, sir. Good study. I mean, I hope you compared between the traditional mini approaches to the lumbar disc to UB.
So actually, we have not any. We don't have any comparison group in this study.
Okay, so this data shows a combined collective data from all the 3 approaches. Huh?
Yes, sir. Yes, sir.
So my question is, within all these 3 approaches, what was the longest duration of your follow-up?
So the first case was performed in January 2025. So almost we have
so it was almost 1 year.
Yeah, yes.
So 1 year is not a very good follow-up length to see for the recurrence of the symptoms.
Yes, sir.
So the major problem with these minimally invasive approaches is the recurrence of the discal symptoms.
Yes.
That has to be taken care of, because once a patient who comes to you for the relief of the pain for discal problem should not come back with the same pain.
Yes.
Great point. Question? Dr. Watanabe will talk to us about minimal invasive endoscopic options for the super aged patient.
Okay, good morning, everybody. And today This morning, my topic is elderly patients, for the super aged patients. As you know, in our country, Japan, the life expectancy is getting, older and older. Like now, at this moment, for female, 88 years old, and for male, it is over 80 years old. And in the future, it is a future projection showing growing from now. And on the other hand, we have been working on a minimally invasive endoscopic surgery for a long time, and I think this concept can be applied to the elderly population. Okay, I would like to share some cases. So first of all, this is a case of CP angle meningioma, which is attaching to the brainstem very hardly. So I always use the exoscope and endoscope, the combined surgery. And now I change to the endoscope. So the keyhole is very small, and we do maximum internal decompression and leaving the tumor layer on the surface of the brainstem. Actually, this is an ordinary way we do, an ordinary option we do even in a younger patient. And this is also the case of a 79 years old female which has a dementia. So only we have to do it just a maximum decompression through a small keyhole. And we can achieve the decompression of the tumor, leaving some amount of the tumor. In this case, actually, we have tried internal decompression just above the tumor, but there was a diploic vein in the skull, and also there's some drainage vein. So, and the tumor was very firm and elastic, so we could not achieve that sufficient internal decompression. So we changed the way. From the frontal side, we looked the tumor from below, from inside the skull. So and remove the tumor, leaving some amount just on the suprasagittal sinus, and we could achieve the sufficient removal in this case. And what about this? This is a 79 years old woman. She had a renal failure and dementia. So we didn't want, she didn't want any surgery. But, the visual function is deteriorating. So we proposed just the decompression of the bone. We don't touch the tumor. We opened the cella and the tuberculum cella and a part of the plana and coagulate them. So we could coagulate the capsular artery, maybe part of the posterior sigmoid artery, which feed the tumor. And also we could have done bony decompression. Also we have done a biopsy, revealed a benign meningioma. And just after the surgery, no improvement. But 1 month after the surgery, she said the visual field is much better. And this is a post-operative MRI, 3 months and 10 months. You can see the tumor is slowly getting down. And we could get 3 years after the surgery. The visual function is excellent. And this is another one, 82 years old, unplugged meningioma, and chief complaint of disorientation and left hem paralysis, and there is a brain shift there. And we didn't want to remove all the tumor because maybe we may injure the surface of the brain. So, so we chose the maximum decompression, leaving a thin layer on the surface of the brain. Especially, we took care about preserving the vessels, including tiny veins. So basically, we leave the tumor, but when we come across the normal tissues, we leave it. We leave everything. And the craniotomy was made at the center of the attachment, and at the dural tail, we used endoscope. And we could remove this much. It looks insufficient, but after several months, it's coming again. Brain is coming again, and patient was really good. She was really satisfied with this surgery. And this is the similar case, 85 years old, and tumor was slowly growing. So we proposed internal decompression without exposing a brain nor CSF. That means this is just after the surgery. You can see no air bubbles inside. And this is the next day. He is using a right hand he's using a chopstick on the right hand. This is a similar case, and I skip it. In the same way, she recovered clearly. And 91 years old female. She had a cystic lesion at the cella, and in this case, gradually growing and the visual function deteriorated, and we chose completely wet field technique with a keyhole, supra-orbital approach, 100% underwater surgery. And we removed the wall of the tumor, and we finished the tumor maybe in 1.5 hours. And this is the last case. Some presenters showed this subdural hemorrhage. It can be done by endoscope in an elderly patient. This is a subdural subacute hemorrhage. In our cases, we make a small keyhole at the center of the hematoma, and surgeons move around the keyhole, and we place the monitors, 2 monitors on the other side, so we could remove the hematoma. Okay, this is my summary. Okay, thank you so much.
Quick question. For that CP angle meningioma, Professor, we saw that obviously shell was left. Does it come down? Does it collapse over time, or seems that it's still occupying a lot of room?
A CP angle meningioma, intraoperatively you're talking?
The CP angle meningioma.
Yes. Yes. You mean after the surgery?
Yeah, after surgery, on follow-up imaging, do you see?
Yes,
the expansion
coming
of
down, coming back. Yeah, of course, yes. Okay, thank you.
Dr. Tammei Trivedi is going to talk to us about evaluating clinical and endoscopic surgery using a mononostril approach.
Good morning, everybody. I'll be sharing experience on mononostril approach. I'm working with Dr. Sudhir and Dr. Deepak at Medanta Hospital. So as you know, that endoscopic approach provides superior visualization and panoramic view and more complete resection. So mononostril approach has provided comparable clinical outcomes in terms of gross total resection, hormonal emission, visual improvement, and CSF leak rates. But some studies have shown that pituitary insufficiency post-operatively is more in mononostril approach. However, nasal complications are lesser. So, patient is put supine and the surgeon and assistant stands on the right side of the patient and the scrub nurse is on the left side. As you can see in this photo, uh, endoscope section and instruments all are going through one nostril, right nostril. So we have a intra MRI suit, so we use it in our cases. In 2 years, in 18 months, we have operated 73 patients, and average age was 47 years, 31 were females and 42 males. And largest non-functional tumor was 7 by 7.8 by 5 centimeter. Largest functional tumor was 6.6 by 2.8 by 2.2 centimeter. And most common complaints was headache, around 56%, blood vision 39%, peripheral vision loss, tunnel vision in 31% patients. 6 patients presented with diplopia, 4 patients presented with ptosis, and a hormonal symptom was found in 30% of the patients. And in 3 patients, that was an incidental finding. So most of our tumors were non-secreting, which constituted 63%. Among hormone-secreting tumors, growth hormone was most common, around 11%, and least common was TSH secreting, which was only in 1 patient. So headache improvement was found in 95% of the patients, and visual improvement was seen in around 86%. Hormonal remission was achieved in 81.5%. And post-op radiation was required in 8% of the patients, and repeat surgery was required in 4% of the patients. Complications were 2 patients were died, and IC injury was seen in 3 patients. Meningitis was observed in 7 patients. Rhinorrhea was seen in 3 patients. Lumbar drain was put in 3 patients, and permanent DI was seen in 3 patients. Hematoma, which needed to be re-explored, was there in 4 patients, and 2 patients required EVD and shunting followed by, due to hydrocephalus. 1 patient had visual deterioration, and post-op hormone deficiency was seen in around 8 patients. Anosmia was seen in 2 patients, atrophic rhinitis in 5 patients, and 4 patients had epistaxis post-operatively. Despite all possible efforts, complications do happen. So one thing is that when the tumor is invading cavernous sinus, then by dissection there are more chances of complications. So you can do radiation, manage it with cyber knife or radiation also, or go for surgery. This was a 53-year-old male non-secreting tumor, and we did endoscopic surgery, but after 4 hours after surgery he had visual deterioration. In post-op scan there was large hematoma and residual tumor. So we again went through endonasal approach, and after second surgery patient's vision improved. The main cause of such bleeding is usually capsular arteries that can bleed persistently, and if not cauterized at the time of surgery, then can result in post-operatively hematoma. Another patient, 63-year-old male, megakaryocytic thrombocytopenia. As you can see in post-op MRI, it was incompletely removed and its capsule is still there, which eventually bled. And this was the CT scan on post-op day 1. So patient GCS deteriorated, so we had to put an EVD and followed by shunt. But despite all these efforts, patient GCS did not improve. He had hypernatremia also, and he was discharged in poor GCS condition. Another patient, 33-year-old female, as you can see, the tumor, the ACA abutting the tumor anteriorly. So while surgery, there was a torrential bleed. So we did a DSA and found an active leaking aneurysm at the A1-A2 junction of left ACA, and it was managed by coiling. So patient was tracheostomized. She deteriorated, but at the time of discharge, she was M6 status and on T-piece. So we discharged. Eventually, she was decannulated also. Post-op CT scan showed ACA infarct, ACA territory infarct, but patient was discharged in stable condition. Another patient, she underwent endoscopic surgery. During surgery, there was torrential bleed, and when we did DSA, then we found that right fetal PCA dissection was there, along with it cavernous and ophthalmic segment of the right ICA dissection was also there. So we had to occlude the parent vessel through coiling, but after that the outcome was not good. Patient had right-sided infarct, for which we did a decompressive craniectomy, but despite all possible efforts, we could not save the patient. So to avoid this carotid injury, the most important thing is the good anatomical knowledge of nag marks in. Second thing is we can use adjuncts like navigation and ultrasound Doppler to prevent carotid injury. So to conclude, endoscopic and mononostril approach is good approach for pituitary adenoma exceed the extent of dissection, and managing complications like ICA injury always requires teamwork. Thank you. I invite you to for the WNS summit, which is going to be held in August 2026 in Delhi. Thank you.
Thank you, Dr. Tanmay. Any quick questions? Yes.
So the problems which happened, which you showed, the patients were performed through a mononostril approach?
Yes, sir.
Okay, so my question is, what would you anticipate any difference in the complications if otherwise you would have done by a binostril approach?
Sir, I have seen binostril in my residency, a lot of binostril cases, but since past 3 years...
No, I'm talking about the data. Have you compared between the mononostril and a binostril approach?
No, sir.
Because, in my opinion, binostril gives you more space.
Yes,
it gives you a chance for a better bimanual dissection, and there's more space. So, logically speaking, binostril would have made some of these complications easier. Otherwise, the data, that is what has to prove.
Sir, you think these ICA injuries can also be... There can be less ICA injuries in...
That is what my question to you is.
No,
do you anticipate that there can be any difference in the complications between the two?
I have not compared, sir, that, but I don't think so.
But if you have data, you can compare between the binostril or mononostril. It would be a good
study.
Retrospect.
Thank you, sir.
Thank you. We are going to move to the next talk by Dr. Virender Sinha sir, and he's going to talk about the optimizing outcomes in pituitary tumors, endoscopic versus intracranial approaches.
Good morning to everyone. First, thanks to Dr. Bansal and Society for inviting me here. My topic of presentation is optimizing outcome in pituitary tumors, endoscopic versus intracranial approach. So if you see the evolution of surgical approaches in 90s, when we started the surgery for pituitary, there was no endoscope. So we were doing the transcranial or microscopic transspinal. Then from 2000 present, it is the endoscopic era. Then current is very important. It is the tailored anatomic based surgery. So we see this diagram. So microscopic era was in 1990, as I mentioned, where the dual prevalence of transcranial and transspinal surgery was there. Then in 2000, endoscopic revolution came. Panoramic view of endoscope made surgery very easy. But presently, it is a tailored era. So first, we must try ETS, but limitations are recognized with the hybrid. We should recognize the limitations. So in the most volume center, high volume center, 5 to 10% of cases we go with the transcranial approach. So message from this slide is the goal is not to complete with endoscopy, but to identify where it fails. So we know that there are 5 flags, red flags in the where we can go for transcranial. Morphology, this is the snowman tumor, which needs transcranial approach. Extension in 3 or 4 years of cross. Consistency very hard and calcified tumor. History of previous surgery and vascularity invasion of the cavernous sinus or ICA. So we must identify the perioperatively to prevent subtotal removal of the tumor. So these this point should be identified before surgery. We know extension of this tumor, it is vertical, so endoscope debulking depends on the gravitational. So if it doesn't come, we can pull, we try to pull something, so we can cause the injury to the this optic apparatus. So transcranial advantage is it directly allows superior to inferior visualization, and we can separate the visual apparatus, we can separate the tumor from the perforator and hypothalamus, and we can prevent the neurological complications. Lateral approach. So biliaris in endoscopic is cavernous sinus and ICA, but there is solution. Solution is transcranial approach, which better identification of the tumor limits and vascular structure and total removal of the tumor. So functional preservation is also very important in any surgery. So direct optic apparatus decompression is better with endoscopic, no doubt, but sometimes it is insufficient fall. So if there is insufficient fall, we pull, so as I mentioned, we can cause the optic apparatus injury. So transcranial approach is better, which enable circumferential decompression, which allows separation of tumor from the perforator and chiasma, and total removal of the tumor is possible. Consistency is very important in imaging. So soft tumor, if we go with this endoscopic, the section-based debulking is effective. But if tumor is very much calcified or firm, it requires 200 microsurgical technique with tactile feedback and sharp dissection. So in this patient, we should go for the transcranial approach. This is an underestimated cost, which already described by other speakers. In 10 to 30% of cases, there is a chronic nasal morbidity in form of the persistent nasal crusting, nasal obstruction, and burning of the sensation in the nose. So although ETS avoid the visible scar, but internal scar can significantly affect the quality of the patient. So this is usually, so we must think this before surgery in an older patient. Other complications are olfaction. We may have some in patient, the hyposmia or anosmia, infection or structural damage in form of the chronic rhinosinusitis, septum perforation. When we raise the head flap, we can injure the septum. So these are the complications which we see in this transfemoral approach. This is very well-known complication. So many previous speakers encountered it, and the 4% we see only in transcranial, but in transfemoral it is 15%, very high incidence of the cesophanuria. So ETS carries a higher risk of intrinsic risk, high flow leak, which may cause meningitis, pneumocephalus, and we may require lumbar drainage. So in these cases, if already patient has been done by transfemoral, we must go for the transcranial approach to avoid the problems. So modern is a hybrid mindset. Microsurgical transcranial excision is not obsolete. It is not a historical footnote, but the decision must be on the individualized person. So what is the final progressing, what we should plan? Endoscopic surgery fails, transcranial route should be done. Don't try for endoscopy again, because there is a lot of problems. It is endoscopic error, doesn't mean you will create complication in the patient. So incomplete endoscopic resection with residual or lateral tumor, for recurrent macroadenoma, we must go for the transcranial route. And if we repeat ETS again, then we may cause the meningitis, so many complications, and patients are disabled post-operatively. Just I want to share my two patients. One patient admitted with headache and repeatedly changing the SPECT correction, but when imaging was done, it was showing the pituitary tumor, and on examination, they were ophthalmic examination, they were bilateral palliatis and bilateral hemianopia. This is the MRI showing the pituitary cellular mass with supracellular extension. You can see the supracellular extension also. And when contrast was done, it was showing a uniform enhancement of the tumor going in the cellular and supracellular region. So we plan to do this patient by transspheral endoscopic excision, but when we operated doing surgery, it was bleeding so much. It was very hyperemic, everything. This is a small video just to show. But finally, we could took the biopsy. We could took the biopsy, and it was we also suspected it may be the meningioma. So we changed to the plan B. Plan B means transcranial surgery, and total tumor removal was done, and patient has a uneventful post-operative period. This is a tumor, very high vascular tumor, and but we could remove it in total. This total removal of the tumor was done. This is a post-operative CT showing total removal of the tumor. This is a corridor which we opt for this patient. This is a post-operative MRI showing total removal of the tumor. So this is another patient where 43 year patient came with headache, vomiting, and visual disturbances. And again, there were bitemporal hemianopia, optic atrophy. So this is the MRI showing the cellular mass with supracellular extension. Again, this patient was planned for the transspheral surgery. And surgery was done, total removal of the tumor was done, patient was well post-operatively, patient was discharged, and on 13th day, patient, this is a post-operative CT showing complete removal of the tumor. So in follow-up on 13th day, he came with the CSF leak. So we put the lumbar there, and but still the patient was leaking CSF from nose, so we repaired it again through transspheral route, and but patient was drowsy post-operatively. So we saw this is pneumocephalus, and usually this pneumocephalus also absorbed, and we put the this reservoir because there was some complete recurrent leak from the nose. So and we connected the EVD, right? So now the patient don't have CSF leak. Now there was a big question mark what to do. Thicoperitoneal, low pressure VPCN, medium pressure VPCN, or we repair again this thing. So what we did the low pressure VPCN were done in this patient. This low pressure, and this is the low pressure VPCN were done. Patient improved. There was no CSF leak, and patient was discharged. So when we compare the outcome, defining success, outcome in the measure with endoscopic and transcranial, total dose resection removal is 83% in endoscopic, but in unseen corners, the transcranial route helps. Hormonal remission is comparable in both visual impairment, high with the endoscopic, and but in transcranial, if it is directly passing the adhesions, this is better. So again, choosing the surgical corridor, optical control, better with transcranial, lateral extension, superior access, fibrous tumor, excellent transcranial, nasal morbidity, none, CSF leak, low, and olfactory disturbances, none with the transcranial. So my take-home message is endoscopy is the first line for treatment for the macroadenoma. Transcranial surgery should be for giant tumors and recurrent tumors, and nasal mobility should be a part of surgical decision making, and it depends on the surgery should be opt as per the individual patient and the clinical picture. So microsurgical transcranial excision remains a vital, not obsolete technique in modern management of pituitary macroadenoma. Thank you very much.
Thank you, sir. Any questions? We can conclude this session, and now we're going to move to the open forum, and I request moderators Dr. Rashid Kataria, Dr. Shikil Uppal, and Dr. Shyam Sundar.
Good morning all. So let's move on to the next session. May I call upon Dr. Bharat Singh Naik, recurrent trigeminal neuralgia, re-explorative difficulties. Dr. Bharat Singh. So as we are running late, so I request all the speakers to stick to the time.
So, good morning everyone. At the outset, I would like to thank Professor Dr. Bansal sir and his team for inviting me here and then giving me this opportunity. I am Dr. Bharat Singh Naik, Associate Professor at Government Medical College, Visakhapatnam. So today's my topic is and difficulties in re-explorative surgery for post-MVD trigeminal neuralgia. And my mentors and my teachers. And overall, total number of cases I have operated MVDs since 2009. Total number is 285 cases. And indications for surgery are refractive medical management and presence of vascular loop and recurrence. And these are the indications. And before going to the recurrent difficulties, let us show the normal anatomy in the first case, how it will be. And here in first case, the rectangular membrane will be clear and transparent, and all structures are clearly visible, and petrosal veins, and then seventh-eighth complex. After dissecting the rectangular membrane, you can see trigeminal root and vascular loop. Both are vascular loop is compressing from anteriorly, and in this regular procedure, will mobilize the root, either root or the root or vessel will mobilize, and then we'll put a graft. Usually I'll put a graft, I'll take graft, a facial graft as a graft, and I never use the Teflon. And all my cases I used facial graft, I got a very good result. This is a normal case, fresh case. And even in normal cases, and sometimes we have to come across difficult cases like this. This is one case, a difficult case. Here you can, after dura opening, you can see the vascular, so many vessels are there, like a vascular nest. And here, and these vessels are obstructing your way, and it's difficult to reach the target area. But still, in these conditions also, we can further proceed surgical procedure. And then only thing we have to do is we have to identify which vessel is compressing and which vessel is the culprit. And here we have to have a little patience, and with your excellent surgical skills, we can able to perform, we can able to do your surgery without any difficulty. And here I have searched for the vessel, which is the culprit vessel, and here, and that is the vessel at the 3 o'clock position, which is compressing the root, that is at the exit point. So the process is the same, and then you mobilize the root and then put a graft, and During mobilization, we should be very careful, and then we should not use any sharp objects, and blunt dissection is the best. And placing graft, and this case went on very successfully, and then patient got very good relief. And like these cases also we can perform with endoscopically successfully. And another case, this is a recently operated case of ectatic basilar artery, which is severely compressing the trigeminal root. Almost the trigeminal root is not seen here, only exiting part is seen at the around 11 o'clock position here. So in this case, and mobilization of the ectatic vessel is very difficult, and during that time it may cause torrential bleed, and we may have to lose our patient. So I tried to mobilize, but I couldn't mobilize properly. And here, and I got a small space here at the around 11 o'clock position, and I tried to put a graft, and then I kept the graft, and I inserted the graft with carefully. But after surgery, a patient didn't get relief. And then on first course of day, again the patient complained that, sir, I have pain still have pain. So I convinced him, and I advised him for other modalities of surgical modalities. And now coming to the recurrent and residual pains. So residual pains will be seen after primary surgery on the day of second or third or fourth day. The patient complains about, sir, I have a pain, still have a pain, but there is no relief in the pain. So what could be the reasons? And normal reasons will be the inadequate placement of the graft, or the graft displacement, or inadequate adhesions releases. And sometimes undiagnosed primary neuralgias also. So in my series, almost total 8 cases of residual cases I operated, re-exploration done. In those 5 cases, they don't have any vascular loop. Though once you enter into the field, and then if you don't find any vascular loop, then what to do? Then I have taken consent, and I convinced the patient attendants that we are going to go for selective rhizotomy. And then after consent of the patient attendants, I did selective rhizotomy for those 5 cases. And another 3 cases, I found very small venous loops, but I had a doubt these venous loop will cause that much of severe neuralgic pain. So still, I kept a graft in between venous loop and the root, but after surgery on second day, they complained about the same pain. And again, I re-explored, and I have taken consent. I have done the selective rhizotomy for those cases. And this is the one video of the selective rhizotomy. In this case, actually, I have done maxillary selective rhizotomy for that case. And the first course of day, again, he complained about the pain. Pain was not relieved. So I have taken consent for another, again, rhizotomy, and then I did mandibular fibers resected, and patient got somewhat relief. Here we preserved ophthalmic fibers and motor fibers were preserved, and this case went on well. And now coming to the recurrent neuralgia post-MVD, the incidence is 10 to 30%, and causes are adhesions. Adhesions may be due to Teflon or facial graft, and new vascular compressions, and graft displacements, and root damage during surgery, in primary surgery. So what are the difficulties we have to face? And almost I have done 8 re-explorations, 7 re-explorations for recurrent neuralgias. And difficulties are adhesions. There will be very dense adhesions between the cerebellar surface and dura, and the system space will be small and it's very contracted, and very dense dense adhesions between root and vascular loop, and course of the root will be altered, and then that will get contracted, shortened, and pulled towards the tent. And these cases are very difficult to create the plane in between the root and the vessel. And this is the recurrent trigeminal which I have done 3 years after my primary surgery. And these are adhesions and in between cerebellar surface and dura. And after two to 3 hours of medical surgery, I could able to reach the target area here. And here I could not able to see anything except some tissue. And after careful observation, I could able to see the root which is densely adherent to the vascular loop. And almost root is pulled up to the sinus. And like these cases, and after careful dissection, and I would able to see some graft which is might be previously placed the graft, and these I tried to create the space in between root and nerve, but I couldn't. And so after this, and I found this graft and tried to pull out the graft, and but I couldn't do that, and I stopped that pulling out the tissue. And here, what the best thing is we in these situations when we can't able to separate the loop with the vessel, better we should conclude the surgery here, and then without damaging any vascular structures. Better we conclude here, and then we can counsel the patient afterwards, and we can give the options, other options to the patient or patient. So this case I concluded here, and then the patient didn't get any relief. And what other treatment options we have? It's again medical management and gamma knife and balloon compression and radiofrequency surgery, radio ablation. And what to do in those situations? And if possible, create the space in between loop and vascular loop and root, and place a graft. In difficult situations, you can opt for rhizotomy with consent. If that is also not possible, better to conclude the surgery there itself, and without damaging any vascular structures. That may cause morbidity and mortality to the patient. And almost all cases, I got good results with rhizotomy. Thank you very much for your patience listening.
Any questions from the house? Yeah, please. Somebody give him the mic. Okay. So one question. So any special reason why you are not using the Teflon and you are using a graft instead?
Sir, actually I started working on this 2009. At my place, actually I didn't get Teflon regularly. So I started using, instead of Teflon, facial autograft I use, and I got very good results. From there, it's a habit for me to use this.
So
And then one more thing is, in literature, what I read is with the Teflon graft, there's some infection rate is little, infections are coming.
So let's
because
have
of
the
that.
opinion from the house.
So, I was also intrigued by this fascia usage that you use. My only concern, I've never used fascia ever. I have always used Teflon. And why I use this is because Teflon has a tendency to create fibrosis, and hence it has got, it does not slip out easily, which is a common cause for recurrence of pain after the MBD procedure. So the use of fascia is only concern is that what's your experience? Does it not slip away after some time, or do you use?
No, sir. Actually, I take little bigger fascia, sir. Sorry. Bigger fascia graft, bigger one.
Another thing is that you showed that was the fifth nerve in one of your videos, was the fifth nerve cut for the relief of the pain?
Yeah, rhizotomy I did, sir. So not under total.
So you totally severed it.
No, sir, with nerve monitoring, with the help of the nerve monitoring, I preserved ophthalmic branches and motor branches.
Okay.
So you should start using Teflon. This is our recommendation because a shredded Teflon, you can transform into a spindle-shaped structure. The maneuverability is also like better. Putting and like keeping the things between the conflict, it is relatively better with Teflon rather than the fascia.
So in my all cases, facial it has given a very good result, sir.
Yeah, but I think
One more thing is autologous graft. It's advantages.
I think this is an autologous tissue.
Sir.
One thing. Then it will still transmit the pulsation of the vessel to the nerve. And the second thing, there are chances that this, because being autologous, this can be reabsorbed in time. I mean, maybe in a couple of months.
It can shrink anytime.
Yeah, and the Teflon gives distance also because it's a solid, partly solid structure, and it separates the vessel. That's the whole idea behind it. So I don't know if you have a good results. This is the surgeon dependent. It's okay. Okay.
Sure, sir. I'll try with Teflon also, sir. Thank you.
Thank you so much. Thanks. So we move on to the next speaker, Dr. Christian Granulo, endoscopic endonasal odontodectomy. Dr. Christian.
Well, thanks for having me here. This is an amazing conference, and I've been learning so much for the last 2 days. Thanks Dr. Bansal and the Endoscopic Society of India. Thanks IFME. So we're going to continue our roadmap down to the skull base, going a little bit further. Somebody may say this is spine. Somebody may say this is the end of the skull base. Maybe both. I have no disclosures. So it's an interesting procedure, and the indications are, becoming less and less, fortunately. But I trained in an era where we're doing a lot of transorals, lots of infection, lots of things that patients not swallowing for a long time. So I was happy to see that there was some other way, and I'm like, I want to learn it, see if it makes sense. So, and these are, a list of indications I'd like you to read. So it's, shrinking compared to the past for sure. Summarizing is really craniovertebral junction abnormalities that can be, congenital, inflammatory, developmental, traumatic. When there is really a compression that's from the front, it cannot be reduced. So it's rarely the first thing you do. The advantages, as you all know, are that you can restore breathing immediately. Feeding is immediate, like I do postoperatively, speech assessment the same day. Patients usually are kept on liquids overnight, and then they resume feeding the following day. If you have problems with the anatomy of the skull base, this is a better approach than go to the dents. You don't need to split the soft or hard pellet. I show you some nuances to make a little bit more room in this very narrow corridor. And you don't need to cut the tongue. You don't need to cut the mandible. And hopefully it's a quick in and out. Why shouldn't you do it, or should you attempt it? I mean, you should learn it. Everybody should learn it. If you haven't done it, the cadaver lab is the best place to learn this. Do a few, you feel very confident. It's deep and narrow. It's difficult, but what is not difficult in neurosurgery? So I think we should all do it. And you can do this with some adjuncts, or you can, it is better in a way because you don't need to do any retraction and all the things that we said that they bring to endotracheal swelling,
oropharyngeal insufficiency that can last really a long time, dysphonia, dysphagia. You want to keep your patients happy. You know, the transoral have been, Dr. Crockett in the UK popularized this, and it's been the standard of care for many, many decades. And there's nothing, again, wrong with it. But I think we can ease the complications and make people resume activities much faster. It's been popularized by Kassan. These are the angles I was telling you about. Every time you do any of this operation, you operate around this region. You want to look at these angles between the skull base and to see between. So it's a line that joins the Nacian with the center of the pituitary fossa, and then the anterior border with the foramen magnum. And so if it's normal between 125 and 143, and then it's not below and above that. Most patients are not symptomatic unless they have basilar imagination to go with it. These are the types, you know that. This is more for the residents in the room. Also, the odontodeum may be another reason why we do this. And anyway, it's well suited for pathologies above the palatine line. I think that's really great. The patient, it's so I tend to do these sometimes as a second stage to my the posterior decompression infusions, and sometimes we even wait for a time to see. So I say for PANNUS, we will wait to see if it resolves. But for something irreducible, there will be then the second stage. This is kind of a little cool trick that one of my ENT colleagues taught me. So you pass NG tubes through the nose, and then that's what we used to do to pull down. There's a lot of stuff, a lot of rubber in the way. We just stitch the uvula and pull down, and we found that to be much better. This is a little bit of the anatomy that you all know. There's really not much to it. You get to the rhinopharynx. We like to do an inverted U flap. You want to avoid anything on the sides. Stay in the midline, and you'll be safe. So don't go look for eustachian tubes or carotid arteries or vertebral arteries. So this is a little bit of the dissection. Once you get through this. Once you get through the midline and you get through the mucosa, then there's some muscle that you can remove to make a room so that you don't need any retraction. And you can do that with impunity. There's no penalty to that. And this is what it looks like intraoperatively. This is a cadaveric dissection, but this is what it looks like, or you hope that it looks like, with C1 and the dents. And so you start drilling and essentially the arch of C1, and then you core the dents. That makes it safer, and then you crack it onto itself. You crack it down. So that's it's a very elegant maneuver to keep things from falling apart. For a matter of time, I'm not going to go through the ligaments and the things you need to respect and cut. But you can do decompression and retraction. You need to be a wise man. And back in the days, we used to think that you could avoid posterior fixation in these cases. It turns out that you probably should fix them to the occiput. And so I think that this is what I do normally now. So this is a patient that presented to my office, to the hospital actually, with a quadriparesis. She was fused, with this construct anteriorly, and you can see here, I don't have a pointer, but you can see on the axial slide, she has this hyper-intense lesion that's pushing on the spinal cord, really massively, and as the intensity of CSF, so we thought this may be a cyst of the joint due to the increased stress from the fusion. So, and that's confirmed on T1 how apo intense it looks. And so we fused her at the back first, and front, and we were able to get obviously through the odontoid and poke into that cyst, remove the wall, and the patient got much better. This is an intraoperative video just to show the anatomy a little bit and the deep corridor. Now we get into the pharynx, and now we get into the pharynx, and so you can see how deep this is, the pillars of C1, and that's the dura at the back there. So in conclusion, this is minimally invasive, or as minimally invasive as I think you can get. I don't think when you fuse anybody to the occiput is minimally invasive, but at least they could potentially swallow better, breathe better right away. It's well tolerated in our series, and you can consider second stage reduction in selected cases. I haven't really talked too much about that, but it's something that you can do. So, any questions?
Thank you so much. Any questions from the house? Yeah, please.
Chris, a wonderful technique. I just want to ask, how frequently do you do this transoral or transnasal odontoilectomy?
I do it a lot, maybe once or twice a year.
Once or twice a year. So this means that you deal with the pathology from the back, mostly.
Back. Mostly, yes. That's a great question. So why didn't you do it come lateral,
yes.
posterolateral?
In a sense, I wanted to ask this.
The fusion, I thought it would prevent me from mobilized things. So she had surgery before and was fused to C2. I mean, I don't know how much I can pull on that cord to get around, because that was really digging into the spinal cord. So that scared me. I don't know that I can. And there was tissue laterally. So
yes, I saw. I mean, probably it was a rheumatoid or something like that, pannus or something. So because the reason why I'm asking this question is because we used to do so many transorals, transnasal odontoilectomies way before the decade. Right. So for the last 10 years, we will stop doing it, mostly 99%, because we have a procedure now which was devised by our own president, Dr. Sharath. I hope he's here. No, Dr. Sharath, DCER. So since the advent of this technique and the Goel's technique, in fact, we have stopped doing it from the front. Yeah. Only in select cases, like when you want to take out the extraordinary pannus from front, right. Then we attack it.
Yeah, that's the only times that I do it. I show you the indications are less and less. I think, for anything, you can just mobilize the dentate ligaments, you get at the front just fine.
Correct.
I have a video in operative neurosurgery where I repaired the dura anteriorly, just coming from the back. Yeah. It's once or twice a year in my practice.
Thank you.
Thank you.
So usually the transoral thing, excuse me, here, I'm here.
Oh, yes, sir.
The transoral thing, when it is fixed from behind already, yes. So the positioning is difficult. So do you find any problem in positioning through the transnasal route?
So thanks for the question. It's another very important point. I feel that for the endonasal, it doesn't really matter. It's not, you can manipulate the chest and get the angle that you want. So I'd rather be safe and have a head that's not moving, or something that moves or gives while I'm drilling on the C2 arch or on the C1 arch. So I'd rather be safe than sorry in those cases. So my experience is once you fix it, you move the chest a little bit and the bed in Trandela move the reverse T as you wish, and it's not a problem because that angle is not going to change. I mean, unless you decide that you need to reduce that patient before surgery, then it doesn't really matter.
Thank you.
Yeah, thank you.
So we move on to the next speaker, Dr. Jayesh Sardara, Extended Skull Base Approach, Clinical Landmarks. Dr. Jayesh.
Good morning to all. So this is about anatomical landmarks of extended skull base approach. So if you see, if you draw a line
from median canal to lateral OCR. So all the cavity can be divided into midline surgical corridor, endoscopic, and lateral endoscopic corridor. You can expose from frontal sinus up to clivus up to odontoid. We have seen just laterally through transethmoid corridor. You can expose from orbit to the petrous apex. This is the area which is unaccessible by the endoscopy. So we'll go start with the midline surgical corridor, midline endoscopic corridor. First entry gate is a sphenoid sinus ostium, very, very important. That is 1.5 centimeter above the choana and medial to the lower one-third of inferior turbinate. That is the consistent landmark, and it gives you access to the entire skull base via you when you open all the sphenoid vertebrae. It's very, very important. Another one is a rostrum of sphenoid. You see the wide sphenoid cavity. It's give you access to 6 o'clock of the position. So while you're doing extended endoscope, will never allow you to lost. So you always keep this rostrum of sphenoid in the center, so it will never allow you to lost. Third, opticocarotid recess. So it's optic protuberance, carotid protuberance, and medial to that is a medial OCR, it's a lateral OCR. So what is the medial OCR? So medial OCR is just a pneumatized middle clinoid process. And when you combine these two medial OCR, it is basically a tuberculum sella approach. So once you do a transtubercular approach, it gives you access to all the supracellular area, but infrachiasmatic, below the chiasma. So, and then the lateral OCR. When you go lateral to this optico and carotid protuberance in lateral OCR, you will expose this. So, you see this, the ICA, and then lateral to this, it's all a cavernous sinus structure. Now, the very important things, if you want to go to this cavernous sinus corridor, and this is sella, and then there is ICA. So the endoscopic classification of ICA is there is a superior segment, there is an inferior segment, there is a lateral segment, and there is a posterior segment. So there is no medial segment in endoscopically. So all the sella tumor which is embedded in the cavernous sinus, you can access through the only the superior and posterior window. You can't go lateral to this. If you want to go back paracellular area, you have to access the inferior corridor of the endoscopy. I said it's very, very important things. Then the white line, if you expose the sella, then this white line is come into the picture. This is the indirect evidence of this sinus, superior intercavernous sinus, as well as tuberculum sella. So if you want to go to the plenum approach, you first open the plenum dura, then you open the sella dura, then you coagulate this intercavernous sinus, and then you cut it, and then you patient with craniopharyngioma. So here is both the tuberculum sella and the medial one, and you are supposed to drill the sella as well as tuberculum celli part. Now important things, you cut the first intercavernous sinus and then you expose like this. This is infundibular craniopharyngioma, stalk, pituitary gland, and so all the tuberculum, transtubercular approach take you the infrachiasmatic window as well as tumor, and it will access you up to the ventricle. So this is a transtubercular approach. In transplenum approach, the very important finding is the anterior entry in the plenum meningioma, the anterior attachment of the dura is important. So navigation will be very useful. It gives you anterior access. You should drill the plenum up to 1 centimeter anterior to the attachment. So how it helps? And then you do that, then you open the plenum dura first. Attachments, your tumor falls, your arachnoid planes remain intact, and you can easily, dissect the tumor, the intact arachnoid, it will fall down, and you can dissect it, separate it from both the ICA and completely in the plenum area. This is a transplenum approach. Now, very, very important. Now, the center is the turbinate. Medial to that is a midline surgical corridor. This is the lateral skull base corridor, and there are 4 gates for that. So if you medialize the middle turbinate, this is cadaveric dissection I have done in to the middle turbinate. The first gate is the uncinate process. It's very important. This uncinate process is the first gate. When you break it, there are upper attachment and the lower attachment. So you dissect the uncinate process, and the structure in front of you is the second gate, is the bulla ethmoidalis. So bulla ethmoidalis is the second gate. Now the advantage of uncinate process dissection is if you follow the upper attachment of the uncinate process, it will take you up to the frontal sinus. You see the frontal sinus corridor. If you take uncinate process down, the inferior part, it will take you to the maxillary sinus. So all posterior wall of maxillary sinus, that's why it's called first gate. And if you open the maxillary sinus, it will take you to the infratemporal fossa. So this is the first gate. Now second is, so first uncinate process, second is bulla ethmoidalis, that is the anterior ethmoid cell. So once you dissect the anterior ethmoidal cell, you enter the third gate. The third gate is the connection joint between the anterior and posterior ethmoidal cell, and that is exactly the ground lamella. So middle turbinate has 3 attachments, and the third gate is the coronal attachment of the middle turbinate, that is a ground lamella. So how you divide the anterior and posterior ethmoid cells? By this, the third gate, that is a ground lamella. Now once you cross that, you enter in the posterior ethmoidal cell, which is larger. Sometimes you may found only cells, and if you dissect it, you enter in the orbit. Directly you'll end up in the orbit, that is a lamina papyracea. So the fourth gate is the sphenoid cavity. So you open the sphenoid, and this is the lamina papyracea, and then you connect the ethmoidal cavity, and all sphenoidal cavity is the orbit, is the sphenoid cavity. So if you close the 4 gates of lateral sclerosis corridor, you combine the sphenoid and the ethmoid. So very, very important, these 4 gates of lateral skull base. Now endoscopically, IC anatomy. So there are 2 corridors. One is the protuberance, that is a paracellular protuberance, the paracavernous ICA, paraclival protuberance, paraclival ICA. This is the horizontal part of ICA, anterior genu, posterior genu, it goes into foramen lacerum, and this is cervical ICA. So this is an endoscopic view of ICA inside. Now the most important part is, now horizontal part of ICA, how you define? By the median nerve. So where exactly you found the median nerve? Median nerve is found is the lateral part of the sphenoid bone and the medial pterygoid plate is the median nerve. This is basically an indirect landmark for horizontal part of ICA. So what is important of that? Because this is very easy to define to start when you dissect it. You start to dissect the median canal, and everything medial and inferior to that, if you see, if you drill this, you will end up in the, this is a clivus, this is a petrous apex. So it will take you to the petrous apex. If you remain lateral to that, it's an infratemporal fossa. Now, if you are doing the clivus tumor and there is a suppose medial extension up to the petrous apex here, so clivus with petrous apex medial extension, and after removal of clival tumor, if you take 30-degree endoscope sometimes, and it will take you, and you will end up in the petrous apex from inside. And the Paul Gardner described this approach as a endoscopic far medial approach, where you can take up to the jugular fossa through here. You have to take a 30-degree scope and the curved instrument in suction sometime. The sixth nerve. So if you cut the dura in the clivus, the sixth nerve is origin from vertebro-basilar junction. So you have to define first. So you first define it, and then sixth nerve ascend, it enter into the meningeal and periosteal dura, and then it ascend in this between the dura and the Derellos canal. Now in the clival, always cut the dura center vertically, because you may cut the sixth nerve or may you injure it. So you define this origin, and then you put a lateral cut and you identify the sixth nerve. Something about pediatric endoscopic approach. So it's very interesting, the pneumatization. So it starts at the 4 years of age. So before 4 years of age, all the sphenoid sinus is complete non-pneumatized concal. So you cannot define the landmark. The pneumatization starts from superior to inferior, anterior to posterior, and medial to lateral. Exactly, this is a 13 years age boy. So you see that before 13 years, exactly at the 13 years, you can define the sella separately from the other part of clivus. So before 13 years of age, don't forget to use the navigation while using the approach. You cannot see the landmarks separately. This is very important. Same happens with the ethmoid and frontal sinus. We'll take just last minute. Now see the nasal aperture before 4 years of age is 6.7 millimeters. So 7 millimeter nasal aperture. So you have to use less than 3 millimeter, maybe a 2.7 millimeter endoscope if you have availability. Or what you can do is a transmaxillary extra corridor, because this nasal aperture will not allow you. Intercarotid distance. So below 10 years, this carotid distance is 11 millimeter average. If you see the pediatric endoscopy, if less than 1 centimeter ICA, it is relatively contraindication. So never forget to define this intercarotid distance while you are operating pediatric endoscopy. So 4 year, I am just leaving fast. 4 year child with carotid clival tumor. So now I'm just summarize it. So you draw the line from the median canal to lateral ICA, and you can access the sphenoid cavity from frontal sinus to the clivus here up to odontoid. For this lateral sulcus corridor, you have to have a transethmoidal corridor, then transpterygoid approach. The most upper margin you can get orbit. Here you can do the orbital decompression. Then you define the lateral cavernous part. If you draw the triangle from V1 from the foramen rotundum and ICA, and you do the transpterygoid approach, you can enter in the Meckel's cave there, Meckel's cave, and then if you go below the foramen rotundum V2 and you expose here, if you remain medial to the Vidian canal, you reach to the petrous apex. If you reach lateral to the this Vidian canal, you enter in the maxillary sinus, you open the floor, and you enter in the infratemporal fossa. So this is basically all the important anatomical landmarks of the extended skull base approach. Thank you.
Thank you so much, Dr. Jayes. Any questions from the house? Thank you so much.
Okay, so I would like to invite you our next NEUROENDCON 2026 in Mumbai in the June. Invest in very, very interesting and Zara Hatke conference as we have enjoyed last time in Delhi. This time we'll all allow you, welcome you in the Mumbai.
Thank you so much, sir. Our next speaker, Dr. Praveen Tripathi. Moving on to a different topic, putting neuroendoscope in the light of Bhagavad Gita for successful life.
Good morning, everyone. Chairpersons, and I would like to thank Bansal sir for inviting me to give this talk. Here is a different topic, putting neuroendoscope in light of Bhagavad Gita for successful life. Let's see. Neuroendoscope, it gives inner vision, and we are taking some lessons from Bhagavad Gita for a successful life. As neurosurgeons, we are trained to see with endoscope in areas which are not visible to naked eye, sometimes not even with the microscope. We go into the corridors which are quite dark, we illuminate and make precise life-saving decisions. But at very same time, at this phase of life, a question arises, are we equally skilled at seeing within ourselves? Interestingly, this is the very question which was asked thousands of years ago in a battlefield when Arjuna stood confused and Krishna in Bhagavad Gita. So in this talk, let's attempt to connect neuroendoscopy, which is our science of inner visualization, with the philosophy of inner realization with the help of Bhagavad Gita. Let's start with a small prayer. Om Agyan Timirandasya Jnananjan Shalakaya Chakshurun Militam Yena Tasmai Shri Gurve Namaha. Why we have chosen neurosurgery? Then we are venturing into neuroendoscopy, exoscopy, and many other facets. Let's see. Let us ask ourselves a question. Are we doing this for money, for fame, for good family life, for satisfaction, to be at peace? We all have some or other answers, maybe all of these. But what ultimately we want bliss in our life. That's the ultimate goal we all have by doing any of these things. Is there any way to be blissful? Yeah, definitely there is. If you follow some manual, and for life to be blissful, a manual should be that for a life. It should have a meaning for the life. It is Srimad Bhagavad Gita. What is Bhagavad Gita actually? It is one of the 18 parvas of hundreds of parvas of Mahabharata, which is also part of Bhishma Parva of Mahabharata, and it's essence of Vedas. It has 18 chapters, 700 verses, and it is a primary conversation between Dhritarashtra and Sanjay. In between that, Arjuna and Krishna. Krishna has spoken 574 verses. Arjuna has spoken 85, Sanjay 40, and Dhritarashtra has one verse. We have 10 minutes. Can we understand this Bhagavad Gita in 10 minutes? No, not all. It was spoken nearly 42 years ago in approximately 42 minutes. At least 42 minutes are required. Requires 4 hours to recite and nearly 4 decades to imbibe the concepts, and requires whole life to practice. So there are 3 routes which are given in Bhagavad Gita. These are Jnana Yoga, Karma Yoga, and Bhakti Yoga. And 18 chapters which are corresponding to 18 corridors of endoscopic approach to brain, What is the relevance with neuroendoscopy? With neuroendoscopy, we do minimal invasive, we have clear visualization, controlled trajectory, triangulation and balance, and continuous irrigation. And these are akin to MSAS skills, samyog, darshana, dharana, samatvam, and purity of thought. The relevance that we can see when Arjuna was into the middle of battlefield, he was bewildered, he was confused, and after listening to Gita, he was quite confident. Similarly, it happens in our lives also. We are very confused. Our relatives are there, and if we see a situation of Arjuna, he was seeing relatives in front of him. He was thinking about what will be final outcome of the war. There will not be any progeny to rule. Who will care the female? He should surrender. And similar questions, they come into our life also. Whether we should join in corporate or government setup, SR, PDF, private practice, own setup, freelancing, MLC, litigation, big cases, money versus family, whom to marry, who will enjoy. These are the things. And same situation like in a middle of battlefield. So what are the topics which are discussed in Bhagavad Gita? These are about ourselves. Ishvara, Jivatma, Prakriti, Kal, and Karma. The first principle of neuroendoscopy is vision and clarity. And with a blurred vision, we can mean the difference between precision and complication. Similarly, Arjuna also begins with the confusion and he surrenders. It is the very first verse where Arjuna surrenders. It is spoken in 2nd chapter, 7th verse. Karpanya dosho bhasvabhava prachami tam dharm sammud cheta yacheha sannishitam bruhidanme sisiste aham sadimam tam prapannam. He admits that I am confused, please guide me. So who is the best person to guide you? The Guru. In our life, the best person to guide is our God. Bhoktaram yaktapsam lok sarvalok maheshwaram suidam sarvbhutanam jatva mam santim ichchati. So accepting the confusion and surrendering gives us the first lesson, which is there in 2nd chapter. The change. The only constant in life is the change. By adapting neuroendoscopy and other procedures, day and day advancement, we are accepting the change, but it should be in the right direction. Dehino asman yatha de kaumaram yavanam jara tatha dehandar praptir dhirastatna muhyati. Do we really understand who are we? Are we the body? We say, this is my body. We say, this is my eye. This is my ear, nose, hands, legs, and flesh or skin. These are my. So my should be separate from these. So who am I really? This is the question, and the answer is in Bhagavad Gita. Second principle is focus and precision in neuroendoscopy. Similar focus is being taught in Bhagavad Gita. Vyasatmika buddhireke kurunandan bhavishakayantas buddhyo vyasayinam. Those who are in the path are resolute in purpose and in their aim is one. O beloved child of Kurus, the intelligence of those being are resolute in many branched. Third is navigation through complexity. Two ventricular system in two patients, they are different, and we are adapting. And this comes from yoga. Yoga Thakur karmana sangam tyaktva dhananjaya siddhya siddho samabhutta samatvam yog uchyate. And the perfect yogi who is like a tortoise, when the adverse condition comes, he shrinks himself, and after adaptation, he moves forward. This is the thing which we can also adapt. Gita teaches us moderation. Excess in anything leads to imbalance. In surgery and life, do what is necessary, not excessive. And illumination, that is the fifth principle in neuroendoscopy. In darkness, Krishna promises, Tesamevanu kampartam hamagyanadam tama nashamyat bhavasto jnana deepen bhasvata. Those who are surrendering, those who are wanting Krishna, he illuminates their life with lamp of knowledge. Once knowledge has come, skill and wisdom, they give rise to excellence. But one who is getting excellence, he must be at peace and be steady like his ocean. Never bewildered by the rivers entering the flow, entering into Apurimanam Achalam Pratishtam Sodramapa Pravishanti Yadvat Tadvat Kama Ayam Pravishan Sarvesa Shanti Mapnot Akam Kami. And seventh is the obstacles, they always come, the complications, they always come. Every surgeon has faced those difficult moments. The Gita gives a timeless principle: understand prescribed duty, acceptance of the outcomes. Karmanyevadhikaraste ma phalishu kadachan ma karmphal hetur bhumati sangosto karmani. When we operate, we control the process, not the outcome. This is the mindset which reduces fear and enhances performance. And it also teaches us to prescribe duties for society, for foreparents, for nature, and be always thankful. There is always something for being thankful. And it also makes us leader. Yat yat acharit shrestha tat tad devi charujana yat cha yat pramanam kurte lokas tad anudhyate. We need to focus and develop a leadership quality, and we should be aware of the false ego. We always think we are doing this. No. Prakriti kriyamana gunas karmana sarvasya ahankar vimodatma kartahamiti manyate. The spirit soul bewildered by influence of false ego thinks himself is the doer of activities that are actually carried out by the three modes of material nature. If we remember these, we can connect to the limitless and become limitless. These are our scriptures. By connecting them, we can become limitless. For ideal life, we have a manual called Bhagavad Gita. For ideal family, we have a manual called Sri Ramcharitmanas. We need to choose a perfect hero. I have chosen mine. Have you chosen yours? And the thing is, what are the principles and their akin things? Neuroendoscope principle, minimal access, it gives same principle, ahimsa, kaushalam, target sensitivity, ekagrata or one-pointedness, broad lens clarity, vivek, and bimanual dexterity, karma yoga. So in conclusion, surrender to truth, act with clarity, and do not fear. The neuroendoscope helps us to see within the hidden corridors, and Bhagavad Gita helps us to see hidden within ourselves. One gives us precision in action, another gives us purpose in action. And when precision meets purpose, that's where true success lies. The ultimate assurance which has given in the last chapter of Bhagavad Gita by Bhagavan Krishna is Sarva Dharman Parityajya Mamekam Sharanam Braj Aham Tvam Sarva Papabhyo Mokshishyami Ma Sucha. This is the only mantra which comes as the essence of Bhagavad Gita in the last chapter. Abandon all varieties of religion and just surrender unto me. I shall deliver you from all sinful reaction. Do not fear. So it makes us fearless. Thank you for patiently listening and questions. You are welcome.
Thank you so much, sir, for a very nice and a different presentation. I just want to ask you, how much time it took you to compile Bhagavad Gita with neuroendoscopy?
Actually, when you are practicing both are full-time process. What you need to do when you are learning, you are going into in this thing, you dive and you get an insight. So every day I get one insight from both the fields, and both the fields, my patient is daily teaching me, and that is getting correlated with Bhagavad Gita and the scripture. process. That is how it is.
Thank you so much, sir. Any questions from the house? The best thing was the analogy you have made between the neurosurgeon and the Arjuna. So our job is also very stressful, no doubt about that. Nobody can say that he doesn't have any stress in today's time, no?
Yeah,
So,
we all have stress, and that is how it started in my life. By surrendering to this scripture and Lord, you remain calm at all the times, because you know there is somebody to take care, and it is the one who is operating you. In operating field, we are operating, we think that we are operating, but many times a question comes and a click that is given by inside, given by resident, inside given by your technical staff or somebody else. It just gives you a click, and that saves the life, that
so
changes the
is this
decision.
practice helping you in your neurosurgical practice, like explaining the concern, cracking a bad news and all?
Sir, day in, day out, every time, every time. Yes.
Thank you so much. Next speaker, Dr. Rupesh Kumar from Chennai, and he will be talking about extended endovasal approaches for craniopharyngioma.
I think most of us has attained nirvana after the speak by Dr. Praveen. Thank chairpersons and colleagues and friends. I'll move on to one of the challenging topics in neurosurgery, the craniopharyngioma. A lot of questions in mind, which approach to do, transcranial endoscopic, but then the questions which we should be asking ourselves is within the radiology. So where exactly the tumor, how its surrounding, what is the contents, and how we can approach it. For endoscopic, there are many classifications, but when, for endovasal approaches, I think Dr. Kassam's classification still holds good. Type 1 to 4, wherein type 2 and 3 are better managed with endoscopy, whereas type 1 and 4 better by microsurgical approaches. Type 1 pre-infantile can have a both endonasal as well as microsurgical, but if the tumor comes down into the cell, I think it is better done by endonasal endoscopic approach. Once you decompress the cyst, then the cyst wall becomes flowy and floating, and then you will be able to deliver it safely without major issues. So type 1 infundibular, if it is an intracellular, then I think a good way is to do endonasal endoscopic. Coming to this type of tumor, it's a large tumor, the solid component is in the base, the cyst is on the top. And again, if you can remove the solid component, then cyst automatically blocks. You can see that we're working through the stalk is splayed around, and you can use the angle scopes, and you can start releasing the tumor in pieces of it. So once you remove the solid components, then your cyst can be decompressed, and then the cyst wall can be dissected all around and can be safely removed. As in this case like this, we can see that, so the cyst wall is crumbled, and after the cyst is evacuated, and you will be able to remove the cyst carefully and safely without major issues. So these type of cases, though the tumor looks bigger, but then endonasal approach can actually give, because this tool in the midline, and you'll be able to dissect it out and safely remove. And you have an advantage in going through and then working under the chiasm, so that you can achieve real good visual decompression and most of the cases, and thereby your visual outcomes are much better by endonasal endoscopic approach. The beauty of it is that you can also go into the ventricle and then make sure that your tumor is removed, and you can see that the floor of the ventricle is also intact. But coming to tumors like this, thick capsule cyst, one issue is that you may be able to, if a patient comes with an emergency, you can do an Omeyer reservoir into the cyst so that the cyst crumbles. You can come back after a month, the cyst is already decompressed, and then you'll be able to deliver it in a much easier way than it was. As in this case, you can see that an emergency Omeyer reservoir was placed 1 month back, you come back again after 1 month, and then you do a cellular craniotomy, something like this. So you can use this as a reconstruction tool also. You can hinge it down and then go into the tumor and start removing this tumor, and you can see that. So I just quickly scroll through it. So you start decompressing this tumor, and then you go. Because Omeyer reservoir is already there, so you can see this is a little bit more solid. What you have seen in this scan is more like a cystic one, but actually you can see this is a crumbled capsule, and it's going all around. Again, it's a binostril technique, so you have 2 hands for dissection. You can use a suction as a dissector, and your instruments also. Something like what you do, real microsurgical instrument applications can also be done endonasally. So as you start decompressing the tumor, you start seeing the Omeyer which is placed already, and that is the Omeyer reservoir. So again, you start dissecting out all the arachnoid, and that actually the tumor has helped yourself because it has decompressed itself well, and then you see that, and then you'll be able to study where you can have a staged approach, invasive approach followed by a major approach. And then you can remove the Omea reservoir from above so that you don't leave a foreign body because it's already exposed into the nasal cavity through a surgery. And that is a massa intermedia. You make sure that you remove the tumor fully, and then you can see that there's a post-op MRI. Most of these cases you can avoid adjuvant therapy if you have removed this tumor. Here you see what is a more of a solid tumor, and this is a slightly different strategy. And you can see that this is multiple loculated. So when you can wonder whether we can remove these tumors endonasally or you have to do transplant. You can see that the pituitary stalk is in the center. So you can try to work in both the sides on the pituitary stalk. So here the stalk is slightly more deviated to the left, so you have a good corridor to work from the right side, and then you start. So that is the thing. So again, a dissection is more important without blindly grasping. So use your dissector to dissect out the tumor capsule from the walls of the third ventricle, which are essentially the hypothalamic structures, and then you'll be able to remove the tumor. So though endonasal main concern is that you are blindly removing the tumor, it's not really so. You are doing it under vision with angle scopes, and then you are able to remove these tumors very safely and precisely. And you are always able to enter into the third ventricle, the vision which you never get by a microsurgical approach. And that's a postoperative MRI. Now, most of these craniopharyngiomas, as you see here, essentially midline and then cyst. However, here there's again a calcification. We can see a thick chunk of calcification in the cella, whether we can remove these tumors endonasally. But then because most of the time these calcifications in craniopharyngiomas are not very, very thick capsules, and we can see, as you see like this, again, you try to work to one side of the pituitary stalk here. The pituitary stalk is pushed towards the left side, and then you have a good corridor, and then you start removing. So once you remove all the solid components in the top as well cyst, again it will start crumbling. So essentially the same principles remain the same. So even if it is a calcified tumor, these are amorphous calcium, and you will be able to remove in most of the time. We can use a bone recting to say if required, but most of it will be crumbled, and then you'll be able to remove in piecemeal, and you can see and achieve a good decompression, thereby achieving. So this is something we can also have a reconstruction using the mesh, which can actually act as a solid material in addition to your thickening. Now, what you saw the calcification was in the down. Now, what if the calcification is a little bit more above? Still, you'll be able to achieve because there's a cyst below. So once you decompress the cyst, you also have a corridor to work around, and then you'll be able to remove. You can see multiple pockets of calcium here in this craniopharyngioma. Here you are working on both the sides of the pituitary stalk, both towards the right and left, because you can have equal space in both the sides. Right. So once you start decompressing the cyst, the stalk becomes a little bit more pliable, so you'll be able to have some room for manipulation. You can see there's a big chunk of calcification tumor in the middle of the tumor. So you'll be able, after the dissection, you'll be able to remove this tumor, the calcification of the tumor very safely and effectively. And you can see gently rocking movements, you'll be able to dissect it out and remove it without major issues. And then you can see that the stalk is in the midline. Again, you have a good view basically. So most of these times you can see you are able to achieve a GTR, and then you are able to avoid an radiation. What if some cases comes like this where there is a cyst above and then the cyst below with a solid component, and this cyst, you're not sure whether it's a tumor cyst or an arachnoid cap, but then you can have a staged approach like this. So you come from the front ventricle, and then you fenestrate that. It's more like an ependymal cyst, which is blocking the foramen of Monro, causing unilateral hydrocephalus. And then you can also do a septostomy, and at the same sitting, you can also do a transnasal approach and then get the tumor and the cyst above. So you can have this something like a dual approach wherein you use an endoscope from above and then an endoscope from below the same sitting, and you're able to achieve a gross frontal excision in most of the time. So coming to the literature now. So yes, craniopharyngioma is a topic of debate, but more and more the world now has moved towards endonasal endoscopic approaches because there is a good visualization and able to achieve a much better giving results, especially with the visual outcomes are much better with endonasal endoscopic route in most of the studies. And even in endocrinological outcome, they say that because you are able to see these perforators very carefully and meticulously, you're able to preserve all the perforators to the hypothalamus and the hypophyseal stalk, which is not possible really in a microscopic approach because majority of the time they are blind. So even the long-term outcomes are also much better in endonasal endoscopic approach. So craniopharyngiomas by a large disease now is more and more towards the basal skull-base approach rather than unless the ones which are more lateral multi-compartmental where you need to go, or we can also plan a staged approach. So the best approach has to be decided based on the morphology, and the midline ones, even if they have calcifications, have still a good corridor to go from below. And even if there's some hydrocephalus, if there is a large cyst, you can always stage it, put an Omea reservoir, wait for a month, allow the cyst to crumple, you can go from below and then you'll be able to remove it. Work with a good ENT colleague so that you will also have a good reconstruction. Most of these, you are entering into the third ventricle, it's a high flow fistulae, and then your results may be disaster if there is a CSF leak and ventilators, all the hard work is gone. So better work with a team so that your hands are also free and you can achieve a good outcome. So these videos are also available in this barcode. You can also access to that outcome. Thank you very much for this patient.
Very nice presentation, sir. House is open for questions. Any questions?
Rupesh, excellent presentation as always. So my question is, how is the post-op period for these patients? You know, endoscopically it looks very nice, but what is the post-operative period? I mean, is it very stormy? Just by pulling these tumors from the endonasal route, you know, we normally when we do, I mean, that's just a question to ponder upon. When we do from cranial, you seem to have a more greater sense of control. So you can use the scissors to very sharply dissect the tumor from the gliotic plane. So the injury technically may be less. In endoscope, most of the surgery, you're just pulling it. You may do some dissection, but most of the surgery is traction. So how is the post-operative period? Is it very stormy? Are they on replacement drugs for rest of their life? How is their growth? So have you analyzed these things?
Yes, sir. So not by literature actually supports more endonasal, but my own experience, I done a lot of this microscopically. But the endonasal patients are looking immediate post-op, actually they are much better than the ones which are done by microscopic approach for some reason. Maybe it all looks like they are pulling out and grasping, but actually it is not the case. Unlike meningiomas where it's adhesions, most of the time these craniopharyngiomas are not really attached that adherent to the walls of the third ventricle. So though it looks like post-operatively, in the post-op period, endonasal cases are actually, these children most of the time, they are much brighter and they are not like a microscopic approaches. Some of them have tolerated very well. Only problem comes when there is a CSF leak, so that is the only thing which can pull them down. Otherwise, but most of these patients do require endocrinological, they are all in the post-operative pediatric ICU, manned by the pediatric intensivist in association with the pediatric endocrinologist. So that is also equally important. Absolutely.
So that was an excellent presentation. Really.
Thank you.
What is the incidence of post-operative CSF leak? You have opened third ventricle in most of the patients, and how do you manage that during surgery and after?
Yes. So because this is a high flow fistulae, all these cases we do gasket technique. So gasket technique, it is a multi-layer reconstruction. So I didn't have time to do, so that itself is a topic. So what we do is we place an inlay graft, probably an artificial dura, balloon it out, and then the second layer will be the bone, the nasal cartilage, which is most of the time device, and then we use the facial lata. So the facial lata with the bone cartilage goes inside the defect and acts like a gasket technique. And then the nasoseptal flap goes to pillow. So it's a 3-layer closure almost always, and we don't leave a postoperative lumbar drain. Don't drain because there's a gasket technique, actually it is counterproductive. So you want some CSF force to push from below so that your gasket supports it. If you do a lumbar drain after gasket, the gasket won't fit properly. So there still can be a chance of CSF leak. We had one child with CSF leak, but then if there is a leak, we immediately go in. There is no question of waiting for lumbar drain. Go in and then again find the defect. Most of the time there will be a small gap. We again put some fat graft and then we do it off. No. Most of the time once in recurrence is difficult because these are small cysts. We will not be able to target it alone.
Last quick question.
Sir, one quick question, sir. CSF leak part you addressed. One more question was there. What about post-operative, say, hematoma, or how do you take care of the tumor bed hemostasis in this technique?
Warm saline irrigation. Most of the time that is sufficient. Only thing is don't irrigate the saline from the nose inside because you'll take all the dirty material inside. So take a long suction cannula that itself has and then do saline irrigation inside the third ventricle and then allow it to come out rather than allowing all the sinus fluid to go inside the ventricle.
Okay. Thank you so much, sir.
Okay.
is Dr. Santanu Kumar Bora here for the presentation? No. So thank you so much, everyone, speakers. We'll end the open forum session here. And for the next session, that is colloid cyst, I call upon moderator, chairpersons, Dr. Pankaj Gupta, Dr. Ashutosh Kumar, Dr. Komal Prasad, and Dr. Jitendra. Thank you so much.
Hello. Good morning, everyone. So, may I call upon Dr. Hemant Bhartiya for presentation of his own colloid cyst, his experience about colloid cyst. Sir, please. And because of the shortage of time, we are not allowing Dr. K.K. Bansal to speak his next lecture. So, Dr. Avdesh, you be ready.
I think Dr. Bansal, you may present because it seems it has not come from there. My presentation. पेन ड्राइव उसमें स्लाइड ऐड किया हुआ है.
Well, if it is taking time, we can ask Dr. Avdesh to present. Are you ready with your presentation?
स्लाइड में नॉट देयर. नहीं. ये बंसल को देखो ना. या ये हो गया. वो काम. नेक्स्ट ये कर दो. अच्छा, तो इससे करूँगा ना नेक्स्ट. हाँ, इससे भी कर सकते हो. इससे भी ये पॉइंट दोनों चालू करो. So today I'll be talking on colloid cyst. Okay. So we'll not. So controversies in the management of colloid cyst. Before I start, I must appreciate the previous speakers of the previous session with all wonderful papers, and Dr. Tripathi, who spoke about Bhagavad Gita and the endoscope and compared neurosurgeon with Lord Arjun. हमें तो सब वो दिखते दुर्योधन काफी ज्यादा. खैर, but it was wonderful his comparison, comparing this, but with a word of caution that once you concentrate on particular thing, what is said the last chapter of Gita, and then you stick to that. In neurosurgery, you might have to change again from, if you convert from microscope to endoscope, then again you might think that you might go back to endoscope. So, no disclosures. Everyone knows about colloid cyst constituting 0.5 to 1% of the primary benign tumors and others. They may be asymptomatic or symptomatic, where we treat them, either observe them or just treat them, and the symptomatic with either headache, different types of raised ICP, sudden fall, sometimes they present in emergency with sudden death. So the aim of surgery is whether you do endoscopy or you do microscopic, is gross total resection or it is acceptable removal. Now the management options are different, you can see them. And with the endoscope and microsurgery, one sometimes get confused which way to go, this way, that way, or either way, or another way. And so it looks very good when we started this, as Dr. Sarat Chandra said, in 2000 or 1998, we got the endoscope almost same time. And we attended a workshop there in Delhi that was in G.V. Pant, that was organized in the year 2000, I think. So we were there together. This looks so good that yes, you have aspirated and the arachnoid, the wall is, you can forward, backward, upward, downward, twisting movements. You can take out the wall and there is no bleeding here. So everything seems to be wonderful. It's good. So, as I said, this way or that way, but Dr. Sarachandra also said one thing of caution there, that these, as they are adherent there in the roof of the ventricle, and there is a vascular supply there in the posterior part, one has to be very cautious about that every time. It is not like that. What I just showed you the beautiful video that we could excise them and there was no bleeding. So it is not. And this is the old traditional, the gold standard, transcallosal approach. So one can take out the tumor with the transcallosal approach and without any bleeding or so maybe because the posterior part is bimanual. He also said of the biportal in endoscopy. Why? Because you need to separate posteriorly and to take care of the vascular attachment. So here in the microscopy, you can take out with bimanually these tumors with this approach. You see that almost the whole of it has been removed. And then you can see the foramen of Monroe is okay, looks good. This is another patient, see that now we started doing endoscopy, tried with the endoscope, coagulated the wall, tried to aspirate the contents, but they were very tenacious and the cyst was firm, so it was not possible. We tried for quite some time, but it was not possible to remove with the endoscope. So switched to, say with the same opening, slightly bigger, dilated that corridor, and with the cortical transventricular, of course, because we had already gone through that, and we could remove the cyst completely. Now you will see when it comes out, there is a solid ball-like, so that those they cannot be. You see this coming out as a solid ball. Yes, the whole of it has come out. So these are difficult cysts which you do with endoscope. Now there is a colloid cystic score, which cyst you should operate with and alarm you. If the score is more than 3, definitely you should operate them. because more than that is high risk cases. Whether normal size ventricle you should do endoscopy or do microsurgery. We have done 2 or 3 cases, but we would say ultimately after doing 55 cases that you should not try in normal size or small size ventricles because there are likelihood of damaging more than that. You can see this in normal size or small ventricle. We have done it long back in 2006. This patient was, and we could do it. You can see the complete removal. But now we said not to do, like in other surgeries, like those who were doing cavernous sinus surgery and doing total intracavernous removal. Afterwards, they started saying, no, don't do that, because morbidity, mortality may increase. Similarly, like MR imaging, if your MR imaging shows on T2 hypo-intense MR images, then one has to be cautious of doing endoscopy because this may be very firm inside hard, solid, or tenacious, which it will be difficult to aspirate. You can see these hypo-intense on T2. So that is one thing. Now, with the endoscope, you can see this is left side, so one can go from left side and you can remove, but immediate apostrophe, there is small hyperintense, hyperdense lesion seen after 1 year, then after 3 years, then on follow-up after 9 years. Definitely, they grow very slowly, but still when there is residual, they grow. And that is why I said gross total removal or acceptable removal. And then we operated her in after 12 years, reoperate. You can see with the endoscope itself. And then we removed it. So what we consider is about endoscopy versus microscopy is gross total removal. So what is residual left? And the residual will recurrence or reoperation naturally will depend on your residual. And then overall morbidity and mortality. So one can see from this slide that gross total endoscopy is around 60%. Here you can have more 97%. Naturally, the recurrence will be more. Mortality does not much of difference. Reoperations will definitely be more. So these are meta-analysis, but proponents, because I have been talking and I was talking about the endoscopy for many years, 25 years. And now, as I said, maybe shifting back to the transcallosal. You can see, but none has compared this, that they don't show any bleeding in the all series or any presentation. You hardly see somebody showing you the bleeding which occurs in doing colloid cyst, and the vision becomes blurred, dirty. Even after irrigation, then it is not as clear as when you start it. So these were our cases. This was a large, I think, large, not the giant, maybe nearly giant, large, but this was done large with the endoscope. We tried to see this, and initially you will inspect the whole of the cyst, occupying whole of the foramen, and there is a lot of bulging there. And then you coagulate, and then you aspirate the contents, you see, gradually. But with difficulty, not much of it is coming here. Some part, and then the vision gets blurring, and then more blurred, and then bleeding, and then you don't see anything. You try to remove the clot, and then you convert it to microsurgery. Okay. These are some cases, so I'll not go into the details. Yeah. And another one, you see this. So after coagulating and you open with the scissor the capsule, then aspirate the contents and but now these contents after trying for quite some time are not getting aspirated, and then when you try to pull, as I said in the beginning, and Dr. Sarachandra said that posteriorly that vascular attachment, you can see that it starts bleeding. Some bleeding, and if it starts bleeding, then you don't see anything, and then you have to convert back to microsurgery, and then you remove the remaining of the cyst. You can see that has come out. So through the same corridor, and see the intact foramen, and can remove with the microscope. So this now one represents the what I say. They don't show these bleedings. How much? How many cases? So it is about 20%, 25% reported by Schroeder. Now Schroeder has also accepted it, and he has reported 25% converting into back to microsurgery. See this. What happens here? Trying to remove, and then you take out the whole of it. Sometimes you take out a little indentation, and then again you go back and do the same corridor with the microsurgery. You do it and remove the whole of it, the clots. They have been removed. So it is not that I'm not propagating or I'm not criticizing. One has to be cautious about which approach we should take. I think one slide I had added there, and that has not come, so it is from the pen drive, that what cases you should. So in a small size or normal size ventricles, we should try to avoid endoscopy, try to avoid. Or with the navigation one can try, but still one should avoid. Or in a large or giant colloid cyst, or if the wall is very vascular, or when you see on MRI, with hypointense T2 signal, that it warrants this to do better microsurgery. And I think if it is too posterior in zone 2, zone 3 of that, then one should also try to do with the microscope. Here you can do the transchoroidal here. Thank you very much for your attention. I think
Thank
that
you very
is
much,
what
sir.
the last line I had said, that the perioperative bleeding, which is troublesome, has not been discussed in any analysis, which I had shown some of the meta-analysis. Thank you.
Thank you, sir. Any question or comment? Sir.
Very good work, sir. I know you've been working on this for a long time. So my question is, have you seen any memory loss? I have seen a couple of patients, and one was a very bright student who was in computer science in US. So she came here, she got operated, she was an IIT pass out, and she was in a situation where she had to apply these faculties. So after that, she had a memory loss for long, and she would always come and say that I'm having issues with memory. And so maybe other patients, we do not try to find out this. But after that patient, I was very, very careful henceforth to look at memory loss. So did you have any such similar experience?
Yes, we have had the memory loss, and we do try to do MSME, means scoring also we try to do, but not very much of the follow-up. But definitely there are few patients who have some memory loss, but not interfering in their day-to-day working, but definitely because some part of the fornix you may damage with the either with the when they are too large and you are trying to remove with the either with the endoscope or even microsurgery also sometimes one can damage. What is more seen is with the endoscope you see larger damage than with the microsurgery. But yes, definitely one has to be very careful about the memory and one should do MSME pre-op and post-op.
Thank you, sir. Thanks for your words of wisdom, of tempering our enthusiasm in going to exclusively endoscopic when we are operating bigger and selective cases where the wall is vascular. That's something we need to learn and practice. And when Dr. Sharat Chandra said, like, is it about the transcortical or which one had the memory impairment? Was it because what we see is generally if we go microscopic, the chance of memory impairment is...
that is not true. It can happen with either. It depends upon how much you are able to save the fornix. So it depends how much is stuck to the fornix, how much is the fornix thinned out. So are you seeing the fornix first? So the relationship of the colloid cyst to the fornix, I think, is most important. Approach doesn't actually make a difference.
Approach doesn't make a difference. Okay.
Sir, I think Professor A.K. Jaiswal sir is doing some study on this. He can share some insights on that.
Yeah, if you stay in endoscope, if you stay anterior-inferiorly, so you can avoid the injury to the thalamostyte vein as well as the septal vein, as well as the fornix also. And the aspiration, sometimes I also got the full calcified cyst. But it comes out you have to have patience for that, keep on irrigating, keep on fine suction with the infant feeding tube, slowly, it will leave its roots and then you can take out. But you have to have patience.
After 5 years, then when you present, then your patience, you lose your patience.
In our institute, we are doing Montreal Cognitive Assessment Test, MOCA, in all interventional tumors. And to our surprise, their memory dysfunction, this score is already impaired preoperatively in most of the patients, although they look normal. And in the immediate post-op, many times it does deteriorate, but in follow-up does improve. It's a very good test, very simple test. On a sheet of paper, you can take out from the computer and then give assessment. It's a very good tool to objective assessment, how much memory is impaired preoperatively and how it is improving or deteriorating the post-operatively.
What we are finding is, sir, there is a discordance between what we are finding in MOCA and our regular MMSE. So there is a discordance, and MOCA somehow gives better understanding of the preoperative cognitive status of these patients.
I think what he is saying is much better. Thank you.
Thank you very much, sir. We'll go to the next plenum. Transorbital endoscopic surgery tones for skull-base lesions. Dr. Adesh Jaiswal.
So at the outset, I am thankful to the organizer, Dr. Bansal, for giving me this opportunity. I am going to talk about transorbital neuroendoscopic surgery for skull-base lesions. So this is a group of minimally invasive endoscopic approaches to orbit and paramedian skull base. It basically comprises 4 approaches. The superior eyelid crease approach, which is most common, and I will be discussing in detail. Other approaches are precaruncular approach, lateral retrocantral approach, and inferior eyelid approach, which is usually transconjunctival. So these approaches can be done either in isolation or in a combination depending on the location and size of the tumor. And this tones was popularized and started by Professor S. Moy, who is from Pittsburgh, and is basically not a neurosurgeon, he is a plastic surgeon. So this is a new approach which is gaining popularity very fast. And what is the rationale? You can conventional craniotomy or transarterial approach as well as endonasal endoscopic approach. But transarterial approach offers distinct advantage over these. It offers direct and shortest route. It's minimally invasive. There is no or minimal brain detection. The chances of CSF leak is minimal and excellent cosmetic outcome. So we operate these patients in supine position with no head fixation device and no navigation. If you have, you please use it. Endoscope holder, in our experience, we find it is essential. Otherwise, in most of the cases, we do not use it. But in this approach, it should be used. Most part of the procedure is done by 0-degree scope. Sometimes you need 30-degree telescope. And instruments are basically endonasal endoscopy, common instrument which you use. And we, in our practice, we do not use any CUSA for these approaches. This is OT setup, just like endonasal endoscopic pituitary as you operate. So this is a case presented with right side proptosis and right side V1 hyposthesia. The tumor is involved in the orbit, going to the middle fossa, cavernous sinus. You can see. This is third video. We have given the super eyelid incision by colloidal needle, then exposed lateral outer rim. We are marking the orbitotomy incision cut. This part of procedure is done by our neurology colleague, Dr. Ravi Shankar. And then we prefix with the mini plate and then delineating the lateral orbital wall by separating the periorbita. And then we encounter the orthozygomatic vessels. We are cutting the upper cut on the lateral orbital rim, then lower cut by using stemental bit, then lateral orbitotomy. And we do not remove the lateral orbital rim. Earlier we removed, now we only make a hinge over it and replace it down. And now drilling the zygomatic bone as well as the greater wing of the sphenoid, you can see the temporalis muscle. Temporal dura is now visualized. And drilling the bone near the infraorbital fissure, then this part is known as sagittal crest. You can see very well the temporal dura. Now collating the meningoorbital band and cutting it. The globe is detected with the spatula and now peeling the temporal lobe from the cavernous sinus. And lateral part of the clinoid process also being drilled out and taken out for better manipulation. And gradually the tumor is in review. This is a V2. And gently dissecting the nerves, separating it, and the tumor is now coming out. Very soft. Intraoperative sonoma. And now piecemeal removal. And now dissecting the tumor capsule. You can see the nerves in cavernous sinus wall is now preserved. And after removing the cavernous part, addressing the part in the orbit, dissecting tumor from the retrorbital fat, and the tumor is now defined, dissecting from all around. Then holding tumor with one hand and dissecting with using suction with the other hand, separating it from all around. And brought in the surgical field. The last part, some adhesion has been cut. Now you can see the optic nerve and the middle rectus and inferior rectus muscle. And now delivering the tumor. Putting some fat, wrapped with the salicel and fixing the lateral outer rim. So this is the post-operative CT. You can see the bone work, the post-op MRI follow, complete tumor removed, the proptosis resolved. A very good cosmetic result. This 1 month about after post-operatively. This is our first case. We have sphenoid meningioma. The temporal was exposed, tumor is dead there, piecemeal resection. And at the end you can see the temporal lobe, the whole tumor is out. This is follow-up MRI, complete tumor removed. This post-operative day 1 and after follow-up 4 months. Difficult to recognize this side patient has been operated. This another patient, cavernous sinus epidermoid going to posterior fossa also. भाई चल नहीं रहा है तुम्हारा मामला खराब हो गया देखो ये वाला नहीं आ रहा ना कॉम्प्लेक्स देना So a tumor is being removed in piecemeal, the middle tumor fossa part. Then going the posterior fossa, you can see the brainstem. And that's after the tumor removal. This is our job. So this is post-op MRI, defusionulated, complete tumor removed. This another patient, fifth sonoma recurrent. The CT removed completely. You can see the bone work has been done. Follow-up 3 months, excellent cosmetic outcome. This is a bony tumor, and after good decompression biopsy was benign ossifying fibroma. This patient has known case of renal cell carcinoma, has orbital mass. Unfortunately, the video is not working. Anyway. In this case, we preserved the lateral outer rim. We did not remove it because the tumor was coming out of that. So we wanted to remove the tumor in toto, but the capsule got ruptured. Very quick removal, quick surgery. Doesn't take much time. So complete tumor was removed. The biopsy was metastasis. This very large tumor, right trigeminal sonoma. We were very scared whether to remove this approach or not, but we did it. So this after removal, middle fossa part and posterior fossa part, complete tumor removed. This is CT after the surgery, complete tumor removed. This patient developed pseudomyelonocele, required LP shunt. You can see that completely resolved. Case of spinoorbital meningioma, infiltrating type. We decompressed tumor, underwent radiotherapy. Another patient, similar case, another side. This patient referred to radiotherapy, did not take because of some issues, developed recurrence, we again reoperated. This patient again outside operated spinoorbital meningioma. We attempted the same approach, could not remove much tumor because tumor very firm, very hard. This multiple tumor, the biopsy was lymphoma. We did same approach. Patient died later on because of disease itself. This case of intertemporal pole cavernoma with bleed. We did same approach. Complete tumor removed. Excellent cosmetic result. Another case of residual spinoorbital meningioma, completely removed. Case of cavernous sinus meningioma, completely removed. Another case. This patient has bony tumor, had proptosis and low vision. You can see in the CT, the bony tumor is seen in the orbit. did craniotomy also in this patient. The tumor was removed. This patient became PL negative after surgery, but later on the vision improved. On telephonic, our resident told that patient able to see television. Immediately after this, we operated this patient fibrous dysplasia, very large extensive involvement. Vision deteriorated on left side more than right side. We were very careful. We could achieve very good decompression of the optic nerve. The patient vision improved following surgery. You can see the optic nerve very well decompressed. This patient has very large tumor, multi-compartmental in the orbit. Same approach, complete excision done. So we have extents of 32. Extents of excision was gross total in 13 and near total in 10. These are various complications. 2 patients died because of disease related, not because of procedure. These are the varied histopathology. To some of the transcapital neuroendoscopic surgery offers excellent surgical result to variety of selected distal based lesions. We acknowledge help of our 2 colleagues, Dr. Shankar and Dr. Abhishek, who is here. They were part of this procedure. And with this, we invite you to our forthcoming PKJN and Dr. D.K. Chabla oration on 11th, 12th April. Thank you very much.
Thank you, sir, for the excellent demonstration of the surgical technique. I would like to ask one question. What is your experience with the oculocardiac reflex, and do you have how often you find it, and do you have any tricks to avoid it?
The retraction of the globe, we keep it intermittent. We do have oculocardiac reflex, some kind of bradycardia and all, but it doesn't interfere. We stop for a little moment, then after we continue the procedure. We do not have any complete asystole in any of our patients.
So the only thing is that you have to keep the retraction intermittent?
Intermittent, yes.
Right. Any other questions?
What kind of retraction you use?
We use a common spatula, bring a spatula.
Okay.
To retract the globe.
Handheld.
Handheld,
Go
yes.
for it.
Handheld.
Handheld.
So you'll leave it in
Yes, yes, handheld.
Do we have any other questions?
CSF leak, we had pseudomeninges in 2 patients. One patient very large, required LP shunt. Other one was case of high-grade glioma in the anterior temporal lobe. He had some amount of bulge, but responded with estazolamide. No CSF leak, no CSF anuria, nothing. CSF leak from where? CSF leak from where? Through the nose, you want to say? And pseudo. No case, no case. The globe is completely outside. We do not go in conjunctiva, nothing.
I mean, it's difficult to believe because you are, like, for example, you are operating on a high-grade glioma.
Yes.
So then you have to open the dura.
Yes.
So you did not repair the dura.
We did not repair the dura, but now we have started taking sutures, but in earlier cases we did not repair. Yes, we do not repair the dura.
So you advocate that it is not required for the dura, and even then the leak does not happen.
In those cases where the leak defect is very large and the internal procedure is done, we take facial attack, keep it there. Yes.
Generally you don't.
We don't do suturing. Earlier, now we have started doing suturing. 2 patients have pseudomeningeal, but no leak otherwise. On the wound side, I have shown you. Yeah, in the lateral side.
But it disappeared.
It did after responded with LP shunt in this patient. Other one required only medical management. This one, very huge pseudomeningeal. दिखाओ भैया. You can see this is completely gone. Actually, this is a very poor patient. He was not refused to come. Our agent took very hard time to call him back. LP shunt. Lembopetal shunt, yes.
You do a thorough ophthalm pre-op evaluation and record it, document it. Ophthalm evaluation for...
Ophthalmology evaluation?
Yeah.
No.
Generally you won't do it.
We are doing outside globe everything. Outside globe. We are planning to do some study to see integrity of the visual system. But overall, this patient didn't have any ocular problem. No percentage of trauma size, many people might be thinking. But no. No ocular complication. One patient has visual loss, that may be because of probably dealing the optic nerve. That's why in other cases we were very careful.
So new
But
technique.
thankfully, the vision improved in that patient.
That's good to know.
Okay, very nice talk, sir. Now we'll, thank you, Jaswal sir. Now we'll move on to our next speaker. I invite Dr. Deepak Mangale, who will be discussing on the anatomical roadmap for tones and complications in it.
Thank you, Chairpersons. Thanks, Dr. Bansal, for giving the opportunity for talking about the tones. So, transorbital neuroendoscopic surgery. Now, this is my team's. Then, charting the untraveled path. Definitely, is a different untraveled path. We are charting this area from the going from the transorbital, and this is the just lateral to the globe. There is no problem about any globe injury or anything happen because you just retract the globe and then going inside. Thanks to Professor Dusikong, where I learned these techniques, and thanks to my boss, Dr. Sudhir, giving me opportunity and also support me in all cases. So eyes are window to your soul according to Shakespeare, but here as a neurosurgeon, when you going through the eyes, you can see the eyes are window to your skull base. So definitely from the eyes, you can enter into the skull base, you are into the middle cranial fossa, you can enter the anterior cranial fossa, into the maxillary sinus, sphenoid sinus, and frontal sinus also. So definitely go up to the gastric ganglion, V1, V2, V3, cavernous sinus dissection, and you have to go up to the petrous apex with this root of this one. So eyes definitely eyes has a 360-degree approach used by neurosurgeons, CND surgeon from the transmaxillary approach, and from ophthalmologists also using this approach. So definitely neurosurgeon have equations of supraorbital, not means transorbital approaches, and ENT means endonasal orbital approaches also get helpful. So according for the anatomy, so this is the transverse fascia, this is the greater sphenoid wing, here is the middle fossa, here is upside is your frontal lobe, here is the maxillary sinus, and this is the ACP, and this is the ethmoid sinus. So you can see there is superior orbital fissure, the area is the middle cranial fossa, here is the you have to work between the superior orbital fissure and interorbital fissure. These are transorbital triangles. We go directly into this. When you drill this area, you get to temporal fossa. When you drill this area, you enter into the middle cranial fossa. When you drill, you can enter into the anterior cranial fossa. That is the beauty of this approach. So these are the landmarks where you have to be straight up to the greater sphenoid wing and superior orbital fissure, inferior orbital fissure. You can drill off this as well. This is the another anatomical landmark: greater sphenoid wing, superior orbital fissure, inferior orbital fissure. This is ACP. This is root of post optic node and optic canal. You can optic strut also. You can decompress the optic node decompression also. This approach with this approach. When you go further, you can go up to the lateral sphenoid wing, and then ACP is there, and optic strut and optic canal also there. So this is the bony window of this approach. When you can start from this approach, you're going up to the petrous apex directly, and you can see the posterior fossa and brainstem. So this is the triangle where you drill the area. This is the most important area where your drilling is required. And after this drilling this area, you entered into the middle cranial fossa and these approaches. This is the aerial view. Same one, same approach, just anatomical diagrammatic representation. So is there. So what is the beauty of this approach? Same approach by telional, supraoperative, eptiosic, and transorbital approach. So you can start with the microscope first, and then after that, exoscope you can also use. And after that, use the endoscope, and you can play between where you are going to the cavernous sinus and anywhere. So this is the with the help of endoscope, you can go up to the downstairs also. So what causes the Sylvian fissure into the frontal lobe, then the temporal lobe, there's a fifth nerve, then ACP, anterior fossa, you enter the MCF, you enter the petrous apex, in the posterior cranial fossa, cavernous sinus. That's the workhorse for the transorbital approach. So anywhere you can mobilize with this approach up to this. Obviously, left means lateral to the carotid artery. You can't cross the carotid artery when going to this approach. So white tones, definitely minimal invasive, smaller incision, less blood loss, no brain retraction, straight to the target, avoid the temporally sac which sometimes happen in peritoneal approaches, then the temporal depression also happens, so these charges are avoided, no exposure of serratus sinus or frontal sinus, so it is a favorable manner access directly on the this one, ACPs and this one, and the mental and definitely is a paramedic upgrade, so it's definitely a game changer according to the CCOM. So the same approach from diagrammatic representation, just orbit, temporal dura, frontal dura, temporal muscle, sphenoid ridge. You can see the MOB, meningo-orbital band. In the same band, you can enter from here also, here in approach. You cut the meningo-orbital band and you enter into this approach. So you enter into the gateway of skull base. So this is the basic concept. I am going to just, video is there. This is a cadaveric video I'm showing. Just split it, the orbital saculi, directly go onto the bone. This is orbital septum. This is anatomy same, orbital group. This is orbital septum. Acromeningeal artery come in the way. You coagulate with the artery. This is a landmark point where you reach to the supraorbital fissure. Then inferiorly go to the infraorbital fissure, and this is the working area. Here is the middle cranial fossa, and this is the anterior cranial fossa last time. So when we drill it, you can see the middle cranial fossa, supraorbital fissure. And when you enter it, this is the meningo-orbital band there. You cut that band, you enter into the cavernous sinus, and then Gasserian ganglion to all the nerves, B1, B2, and B3. So these are the, some levels, mistakes when you start your endo-transorbital approach. How to do first one? First, when you are starting the approach, you start with the extracortical lesion, some the extracortical lesion, some post-traumatic CSF leaks. Then again, if you are expertise, go into the middle fossa and anterior finance like spino-orbital meningioma cases. And next, you can go up to the Meckel's cave or anterior-temporal lobe approaches or internal approach. When it further goes, you enter into the cavernous sinus or major temporal lesions. And then last, you can into the insular gliomas and petrosaphic lesions and sylvian fissure also. So you remember there are 5 bone pillars: lesser wing of spinae, sagittal crest, anteroclinoid, middle fossa, and petrosaphes. You have I will show the video of these 5 bone pillars. Again, same. You on the lateral orbit wall. Just retract the globe with the retractor or anything. After every 10 to 15 minutes, you have to release it. Ask your anesthetist to remind me always. And then the retract, you can see first structure, infraorbital fissure, supraorbital fissure. Drill it. You can go up to the lesser wing of greater wing of spinae. Drill it. You can go up to the lesser wing of spinae. And then this is the lesser wing of spinae. When you go upstairs, you drill completely, the coronal plane becomes sagittal plane. Then it's called as sagittal crest. This is a newborn landmark. You never heard in anatomy what is in the sagittal crest. This first time this happens in the transorbital approach, you see the sagittal crest. You drill the sagittal crest, you can see there is a meningo-orbital band. And we cut the meningo-orbital band, then you know about your microscopic knowledge is perfect about whether to approach and what after the meningo-orbital wall cutting. And the third landmark is the just when I cut this meningo-orbital sagittal crest, I just intradural peeling, we can see these nerves, beautiful nerves. Gasserian ganglia, V1, V2, V3, you just intradural peeling is there. Then go upstairs, you can see the just about go upstairs the anteroclinoid. You drill this anteroclinoid, you can enter into the optic nerve and optic strut also. And then you can see the A1, A2, and this one also. And then last structure is middle cranial fossa when you go laterally, and then more further you can go to the petrosaphes. So if you want to go to cavernous side, you just smile. Just these are the landmark: sagittal crest, meningo-orbital band, intradural dissection, lateral wall exosuit, and you can see all the beautiful nerves. So meningo-orbital band, this is the most important structure. After the greater wing of spinae drilling, lesser wing of spinae drilling, you enter meningo-orbital. You can see, cut the band, peeling, you can enter Gasserian ganglion, and everything is there. So eyelid phase, superior phase, bone drilling, extradural, intradural. So some incisions are, some surgeon different incision. When you're beginner, start with bigger incision, then afterwards come slowly, smaller incisions. So respect the periseptal fascia, fat there. You should be, don't burn the fat. You should be always just incise it and separate it bus. Then this is the ergonomy where you can see you can put your endoscope, then first assistant and second assistant before we are working channels. So these are lateral orbital rim definitely have a greater advantage. When you remove this orbital rim, you have better space, and you can work better with. So here are the landmark of lateral orbital rim. These are the steps. I am not going on the real MOBs is there. I am going straight towards the patients. So these are the patients we operated in last 1 year. These are recurrent end-plaque sphenoid with meningioma. This is a meningioma. This is again same approach. Drilling it, separate the periorbital lateral side, lateral orbital removal, then drill it, and then directly on the tumor. Just to remove the tumor with the help of pulsars. Use the QSAN. This is the last structure. You can use as a cell gel foam and a dural substitute. And this is the post-op scan. Complete tumor out. This is end-plaque sphenoid meningioma. This is a post-op CT scan also, pre or post-op in this one. Another, this is vertebral scar. Another bony tumor compression with optic nerve. So here in this tumor, we have to only decompress the optic nerve. The same approach, same remove periorbital pads, retraction, superiorbital fissure. In this, we have to go up to the ACP, remove the ACP, remove the tumor at the same time, and decompress the optic nerves. If there is fiber of sphenoid meningioma, that is pre-op and post-op scan. Intraorbital intracoronal schwannoma, 55 years, same approach. And here, this is a tumor, schwannoma is coming with a separate from the layers of the middle rectus muscles, and then remove the schwannoma. This is post-op of intraorbital intracoronal schwannoma, and this is vertebral scar. This is a clinoidal meningioma, 50-year male. Again, the same approach. Retraction, drilling, lateral orbital remover, open the dura. With the help with the sutures, you can tracket it and tumor removal. Remove this, and this is, in this case, we have to open the supraorbital also because this is adherent to the sylvial vision. This is the post-op line. This scar. After 3 months, the scar becomes invisible. This is a meningioma, middle fossa, 40-year male. This is video. Same. This is directly after drilling. Dura, this is tumor removal. And this is with the help of pulsars and all this. And this is tumor capsule. Complete. This is pre-op and this is post-op MRI. This is scar. This is middle sphenoid meningioma, 49-year females. The same approach. Same drilling, same. But so tumor is left behind here. So now we're not satisfied about the complete tumor of this tumor. This is corridor. This is the corridor of this approach. This is temporal denate. Same dura tumor to expose temporal, and then cutting. Then facial atta, we use this, and this is post-op. This giant sphenoid meningioma, 44-year female. The same approach, same endoscopic tumor removal, same principle. This is a brain surface after complete removal of the tumor. This is a post-op scan. You can see beautifully all the tumors come out. But in this case, we have CSF leak. We encounter the CSF leak. You can see the CSF coming out of this one. And this patient developed the meningitis. And you can see the CSF leak dripping out from this incision wound. So again taken to the theater, again reopen it and pack with fascial atta and then duragen, so dural substitute, and again suture with some anchoring sutures. And after the 3 months, the leak stop. This is we required. Definitely we use intradural substitute, fat, facial atta, fibrin glue, and extradural pad. This is the technique we use, and this is the post-op scar. And I'm not going into another case. This is cavernous meningioma. In this case, while doing the surgery with the help of QSA, I'm doing the QSA towards the medially, and there is suddenly gush of blood coming out of. See, I'm doing the QSA and removing the tumor at the same time, so blood coming out. So immediately you use the muscle patch and pack this cavity, and then shift it to DSA, and DSA shows there is ascending cavernous artery bleed. So they provide a graft stent, and then after that, the patient, this is post-op scan. So small tumor left behind. So I'm concluding, sir. This is another case I'm not doing. Just take a massive, respect the orbital septum, avoid so that you avoid the ptosis. Use your endonasal experience so that you can help in these cases. Follow the path, GSW, LSW, CRESH, MOB, SCP. Follow small route to unlock the cavernous sinus. Remove the lateral rim to better improve working area. And dynamic retraction should be must. Anatomy is your best friend. Thank you.
Thank you, Deepak. Wonderful presentation. Any question or comment? If not, so we are concluding this session. We are going to next session, for which I am inviting Deepak. Remain here. You are the moderator.
Okay.
And Dr. Avdesh, please. Avdesh and Rupesh. Out.
So now we'll go to the very interesting and exciting session, what is for the future. And for the first talk, I invite Dr. Komal Prasad to give us talk on future awaits. Looking forward to hear from you.
Good afternoon. My talk is on what to expect in future. As we just saw, as neurosurgeons, we are like Arjuna in the morning. We were told about our capabilities and what are our instruments. We have to see, as Deepak just said, anatomy is our best friend. Our best friends are within us, within our brain, our intellect, as well as our expertise, as well as our finesse in our hands. So what we can expect in future is not just to delineate anatomy as a scope, but to see how the future is going to show us as a tool to augment our intelligence as well as augment our capabilities as a surgeon, the surgical finesse. So from vision to cognition, so where endoscopy is evolving is the topic. So we have heard about artificial intelligence, robotics in every field, and definitely in future what to expect, definitely we are not going to miss it in our field too. Augmented reality, artificial intelligence as well as robotics. And there's a method to think about it because we were not knowing there's a war going to happen in March, the new year when we saw in January. So it's in a chaotic world like this. So it's very difficult to predict what to expect in future. But if we have a method to think about it, maybe we can harness, guide further where we want our field to be. Like Henry Ford once said, if he had asked people about what do you want, people would have told better horses because they had not seen cars. It was a new innovation. So he thought about what was the pain point and then he invented something called a car. So if we are asked by technologists, engineers, what do we want? We say better scopes because we are limited, focused, kind of tunnel vision. So this kind of sessions will open up our
thinking to see what else to expect and guide technical people to take us to where we want. So basically, what's the procedure of surgery? We see, we think, and we do. Okay, by seeing, we use instrument to see, whether it is naked eye, microscope, or an endoscope, and then we think using our brains and we act. So in each of these steps, if we consider improvement and future of endoscopy is only confined to that instrument which helps us perceive, then we'll be mistaken. So future holds to augment that aspect of our intelligence as well as the finesse in our hands. Okay, so that's the classical era, the early endoscopy era to transitional stage where we have predictive AI alerts as well as robotic stabilization, and future era where it is submerged, like all the three put together, merging of the three aspects of the act of surgery, that is perceiving, thinking, and doing. That's what happens. Right now, we are concentrating only on the scope, but we need to think about what are the other two. What the way I did is to go through the literature, search with specific keywords to see where these particular aspects of growth is happening in future. The AI co-pilot, AI workflow, predictive AI, AI analytics, advanced imaging, and robotics. So coming to the first aspect of seeing. So we have reached the zenith of what best scopes can offer. We are having 4K resolution, 8K resolution. And what we miss is our need to see to and fro between the navigation as well as what the scope is showing. If we have a unified vision, overlapped as an augmented reality, that's what is going to help us because we need not toggle our attention between two screens. So this is one technique where a guide plate which is 3D printed is placed over, and it obviates the need for navigation as navigation we generally think, and a real-time endoscopic integration is possible. And jumping to the spine again, this is one young neurosurgeon from South Korea I met in Seoul, Busan last year. He has started his own company about augmented reality during endoscopic spinal surgery. So this is a short video from his company, which on my personal mail he was happy to share. What it shows is in the next screen, it shows the most possible site of soft tissue, dura, nerve, bleeding point. So it has its value to show when some bleeding is there, when the vision is blurred, where exactly is the important structure we need to see. Like this. This is another software of the same company, which shows when there's a bleeding. So most possible site where we need to concentrate to coagulate will be highlighted on the screen. It's commercially available. It's not future, it's present. But a better versions of this where it is more accurate is what we can expect in future. Then coming to how AI, augmented reality, is going to help. There are studies. So what an interesting thing, what I noted was when we are peeking to the future, most of the studies are in technological journals, not in neurosurgical journals. So we will miss out if we don't go and explore particularly those technical journals. So these are the ones which, like in this NPJ digital medicine, they have analyzed when AI gives an outline of the cellular floor and an overlap of where carotids are, how accurate is it when compared to, so they gave these similar pictures to a senior neurosurgeon, young neurosurgeon, a resident, and a medical student, and analyzed if given the outline as given by AI, how it improves the accuracy. And they have found the effect of that AI mapping is much more in younger colleagues, whereas when with the senior experienced one, the marginal improvement is very little. So it shows like experience matters, but we can democratize that experience if we have AI. So this is the AR overlay. It reduces the cognitive switching between the screens. Right now we have navigation, neuroendoscopy. If you have one more AR navigation. So then we can switch to one screen where, because it's overlap, we need not toggle between two areas for our attention. So this is the workflow to have a guide plate design. This obviates the need for a navigation as we generally have it, the Medtronic navigation. It has a guide plate which is placed on the nose, which is 3D printed pre-op. And then we have this superimposed image directly on the screen. This is the difference, which is less expensive also. And a short video of that. All these slicer, there are many freely available softwares also which these technologies will use to create the tools which would be helping us. So this is direct superimposition of the carotid, optic pathway, and the cellular floor to make sure, like, because we are operating blind or we are depending only on navigation. If you have this kind of overlap, definitely that will be an added advantage, which is possible, but as of today, not yet into practice, not yet commercially available. But this is what we can expect in the next 5 years or so. This is where augmented reality meets neurosurgery. And the second way is even to obviate that need for 3D printed thing, directly to make the AI machine learning to happen based on your past images, past videos, to match point to point where is the carotid, where is the cellular floor, or where is foramen of Monroe, where is the vein. So it's possible to match point to point and make the machine learn over time without any need for navigation. It shows like how a human brain would have anticipated the structures it will show. The most interesting thing is, like, we perceive only with our vision. Okay, so there are ways in which using machines we can make harness our other senses, like listening to the sound of light. Like when there's thunder and lightning, when there's a lightning, the surrounding air expands and there will be a thunder. It's heard as sound. Similarly, when light is transmitted from a tooltip in the form of a laser, a sound is generated when it's focused around, and that sound will be perceivable through ultrasound probe. It's called photoacoustics. Okay, so this is harnessed in photoacoustic guided surgery, where probes are being made available, but not in clinical use again, but that's what we can expect in near future. Drill, where it has an inbuilt laser probe, which shines a laser to the area, and when it hits the ICA, for example, and the transducer is placed in the temporal region or over the orbit, it picks up that and it gives a 2D image of how far or how near we are to the ICA. Like this is an experimental setup. So if that is the vessel which has a flow in it, the probe will show how close we are and how safe it is to go ahead. So this is again an experimental setup, still not available. It's again futuristic, but it's there particularly Johns Hopkins University. They are the pioneers in this, where they are very well coordinated engineering and neurosurgical team. And also in spine, where to see the perfect entry point, ideal entry point, again this photoacoustics is going to help. So this can be incorporated into a scissor tool or a drill tip, or for internal delivery through the screw also, through the drill tip. That's about seeing and using our other aspects of senses. That's perception particularly. Second thing is about thinking. Using augmented reality and machine learning to see, anticipating the unseen, CSF leak, hyponatremia, diabetes insipidus, and asking, like a ChatGPT, asking what would be the next step, what are we doing? So in natural language, the machine is able to see the video and say what would be the next possible complication. Like, can you segment cellular right optic protuberance in the video? So then it says it will be doing that, and it will be answering in natural language. That surgical VLM agent. Okay, these are the various steps. So there is it should be algorithmic, mathematical. That's the problem with technology, where we learn over years anticipate the unexpected. To train these models requires a mathematical precision to divide the surgery into steps and name it. Okay? And then next is to expect how long the surgery is going to last, to give an input to the anesthesia and other teams. How long it would go, what stage of surgery we are. So that's other aspect. Workflow recognition in endoscopic pituitary surgery. They have softwares for that. And to assess the tumor consistency preoperative using radiomics data. That's another thing which is coming up. Okay. So this is about the thinking aspect. And next is to come about doing. Most interesting aspect, using robots. Robots we used in many other aspects in neurosurgery, spinal surgery too. Then when we think about robotics in endoscopy, three things we have to remember: rigid, soft, and hybrid. I will show examples of each three of these. So these are rigid endoscopes, rigid robotic endoscopes. So they look flexible, but for the sake of endoscopy here, they are called rigid because the movement happens in the surgeon's end. The surgeon moves and the tip moves further. So these are and this is like our Lila retractors, where it's like a snake, toy snake, which each of those terminal segments have a control from the robot, from in the surgeon's hand. This is the rigid robot. And soft robot endoscopes are an advancement where you can see here in the tip, there's a kind of pincer movement which self-propagates. Surgeon's control is less. It feels the tissue, feels this is softer than the adjacent tissue, this is safer, this is not a vessel, and it proceeds millimeter by millimeter, turning one by one. And because it's like a train bogie, one behind the other, follow the leader protocol, where the next step, next bit of that segment moves in the same direction. So this is soft robotics. And next comes the hybrid, to harness the positives of both of these types, where the rigidity is used to proceed further, soft aspect of it, soft robotics is used to ask the tip to move on its own, feeling the tissue. So that's the third aspect. So this is the, particularly because it's neuroendoscopy we are concentrating, we are still not seeing the progress as we can see in other fields like hysteroscopy or even the hepatobiliary system. They are very close to have these clinical applications. Neuro, it's going to take some more time. Okay? Yeah. So this is in bladder, for example. So this is something which for bladder CA, to get into the cystoscope and then locate it, and with the pincer arm to take a biopsy in itself. Seeing, thinking, and doing all amalgamating into a single device. So this is the future of endoscopy, which is a new surgical paradigm, and the day is not far where this kind of images, ER images, is routine in our OTs, where we see it overlapped on the surgical field, and then the AI will be telling us like what's the risk of CSF leak in this case, how close are we with the to the ICA, and to give an input to the anesthetist about how long the surgery, what stage of procedure we are in, and how long the surgery might go further. So that's the cognitive endoscopic platform, a trial, attempt to look into, peek into the future of neuroendoscopy. It is so vast and so exciting that I got lost in exploring the literature about going through this, and I tried to put some of these studies together to make a sense. And as I said, if you have the paradigm of seeing, thinking, and doing, you can know which aspect of progress we are into. With this, I'll conclude. Thank you very much.
Thank you. Beautiful presentation. Because of time constraint, I think I invite Professor Masaya Roshin. We're talking on recent evolution from endoscopy and exoscopic neurosurgery from Gen G to Gen X.
Thank you very much, Chairman, and thank you very much, Professor Tanser, to invite me at this honorable meeting. Thank you very much, Professor. Today, I'm talking about our recent small revolution started from our young doctors, and which make me feel the future of our the neuroendoscopy, neurosurgery in 2035. First of all, let me briefly introduce our hospital. Our hospital is located in north part of Tokyo. And in Tokyo, as you know, there are so many skull-based centers, so many pituitary centers, but endoscopic skull-based center is only 2. And our hospital is one of that skull-based center, endoscopic skull-based center. Of course, we do the microscopic skull-based surgery too, but our hospital has much reputation in endoscopic skull-based surgery and also endovascular surgery. So in Japan, people call us not neurosurgery, they call us endoneurosurgery. So first, in those skull-based cases, we also do the endoscopic surgery as it is ordinary endoscopic skull-based surgery, but we usually do the microscopic, very fine surgery, the bloodless surgical field, and I think it's as much as the microscopic skull-based surgery. This is the tuberculum cell meningioma, this is a metal cave tumor, the trigeminal schwannoma, and this is petroclival meningioma, and this is an orbital tumor, the orbital hemangioma, and all the cases are very good candidate for the endoscopic endonasal surgery. And also, recently, we also started the transcranial endoscopic surgery. If we use the endoscope in the transcranial skull-based surgery, we can approach the same the very small the craniotomy, and the surgical effect is much better, I think. If, for example, if we have this kind of tumor, first of all, we creating the virtual reality simulation image like these softwares. Then we discuss the surgical strategy. This case was referred to us for the transnasal surgery, but I think it's not conventional. Conventional transnasal surgery is not very good option. So we discussed the transcranial approach too, and we could make a craniotomy and we compress the brain. And also in this craniotomy, we cannot see much for the upper regions, so superior part. So we add the orbital limb dissection, and then we can sufficiently find the tumor. But in this case, we discuss the strategy, and patient preferred to the endonasal surgery. So we treat this patient with a transsphenoidal and also transpterygoid approach. So in this discussion, we creating a dry lab in the middle of the neurosurgical world, which we call simulation center. We created those software in 2 computers, and also we use those plastic models, simulation plastic model. Then our resident or our fellows trying the approach they think, and they verify which is a better approach. I will show you also another innovation for our department is we introduced the exoscope for our endoscopic surgery. This is microvascular decompression. The endoscopic surgery is very good vision, inside vision, but if we have a macroscopic vision like this, so we can have much more easy. It makes much more easier to do the endoscopic transcranial surgery. Also, we do the orbital approach too. One of the most difficult problem of transorbital approach is sometimes the surgeon compressing the eyeball or skin too much. But if we use the exoscope together, we can always watch the incision around the skin incision and also deep region. So makes much safer, and also the skin lesion, there is no skin lesion problem. I will show you an illustrative case. This is a young woman with a typical trigeminal schwannoma. She has an abducing nerve palsy. So in this case, the patient was referred to us for the transnasal transsphenoid surgery, and we creating the 3D image and discussing the possibility of the transnasal surgery. Actually, in my opinion, the schwannoma is best candidate for the transnasal surgery. Above all, the trigeminal schwannoma is very good candidate because it's easily dissectable from the surrounding structure, and also often it is very soft, and if there is bleeding, it is easily controlled. So in this case, I think we have a sufficient surgical corridor from the transsphenoid pathway, so we decided to do the surgery. This is the surgical view. This is a pituitary gland, and the internal carotid artery is running around here. So this is not a cavernous sinus tumor. It is a McIlcay tumor, which means it's compressing the cavernous sinus anteriorly. So if we approach this tumor, we have to go through the cavernous sinus. However, the most of the important anatomic structure is inside the cavernous sinus. So if we go through the cavernous sinus, we can safely approach to the McIlcay. And now we see the tumor, and the first principle of the dissection of cranium from the important anatomic structure is sharp dissection. So in this case, I use the sharp dissector, then I identify the trigeminal nerve, then gradually remove the tumor, and finally we can clearly see the trigeminal nerve, and after surgery, she is very good, and tumor was completely removed. And the second case, in this case also referred to our hospital for the endonasal surgery, but when we create the 3D image and discuss the surgical procedure, in this case, her basilar artery is deviated to the lesion side, like this. So it is very difficult to approach from transsphenoidal approach, and also it might be very dangerous. So we consider another pathway. In our hospital, first priority is endonasal surgery. So if it's not adequate, then we consider the transcranial approach. So in this case, we discuss the lateral sigmoid approach, conventional lateral sigmoid approach, and if we see that there is a big petrous vein here, but maybe we can dissect the petrous vein and transpose it. And this is the actual surgery. We introduce the endoscope inside, then we dissect the big petrous vein. Then after that, it was a typical microsurgical procedure. Start the mass reduction. Then we identify the trigeminal nerve, and the first principle, the important anatomic structure must be dissected sharply. So we start using the sharp dissection. Then after that, tumor was completely removed, and the venous arterial component and also venous drainage is identified with ICG. The patient was fine, and tumor was completely removed. And the third case is petroclival meningioma. In this case, the tumor is compressing the basilar artery and involving the sixth nerve. But I think we also discussed the transcranial approach, opening the foramen magnum, then we retract the cerebellum. And in this case, if we perform the transcranial approach, the tumor is behind the cranial nerves. And also, maybe the tumor is strongly adherent to the vertebral artery, or maybe basilar artery too. So it is very difficult to dissect the tumor from the surrounding artery. So we discuss about the transnasal approach, and as we preview the transnasal approach, during the transnasal approach, we can directly see all the important anatomic structure like this. So, in this case, we choose the endonasal endoscopic approach. So first principle is that correct? So 34 minutes, second. So in this case, we dissect the tumor from the surrounding cranial nerves and also basilar artery, and there is small residual on the limited part of the anterior inferior cerebral artery, but tumor was subtotally removed. And she is okay. And main concern, there are so many discussions in this conference and also the previous conference. There is a problem about the skull base reconstruction. However, in our hospital, the CSF leak is past problem. We never have one now because we started the suture with fascia, and also we also use the spinal drainage only one day because the purpose of spinal drainage is to stop prevent the raising internal intracranial pressure during the awakening. So after the extubation, after awakening of the patient, we can remove it. So some people say that the dual suture is very difficult, but it's not matter of technique, it's matter of practice. Because in our hospital, closure is not my surgery. It's the part of our resident and our fellow. Because they practicing a lot in our dry lab, and they can perform easily. I think you don't believe this, but professor from India come to our hospital, and they stay in 1 week here, and now Professor Jaipur already mastered it, closure technique. So to learn the closure technique, you don't have to come all the way to Tokyo. You can go to his hospital. And the discussion, there is the several generation, and our senior doctors start the microsurgery, and our generation X started continue the microscope and endoscopic surgery and the vascular surgery. However, our next generation, they use all the three techniques, and they learn from experts through those techniques. However, in my impression, our resident and young doctors, they are not very good at using the microscope, so they have a lot of time to practice. However, when we introduce the exoscope, they use it, they can very sufficiently use it so after that, our young generation Y and we also have to learn how to use the exoscope. However, for the surgeon who use the endoscope, it is very easy to use exoscope too. So this is our surgical room, and generation Y doctor use doing the surgeon, the main operator, and generation Z have an assistant. And generation X, this is our associate professor, he teach how to do that. And what the difference from our generation and young generation, why they can use exoscope, endoscope so easily, because there is a different from the education. What education? The video game. So our big generation use the 2D image as a video game, but they already use a 3D image. So what happened after 10 years? The next generation, Generation Alpha, already they are inside the video game. So I think in the future, microscope is used very less and less, and instead they replace the exoscope. Then the endoscope is also improving because the Generation Alpha, they are going to use exoscope and endoscope. Thank you very much.
Thank you, Dr. Singh. Very exciting and very
innovative talk. And we have only one quick question, Dr. Smith.
A very absorbing lecture indeed. Professor Shen, I should congratulate you for the wonderful work that you're doing there. And we all aspire to learn from you regarding this. My query is, you use a special software for creating that schematics,
Yes.
which really helps you in designing your surgical approach.
Yeah.
So what is this software? Is this a special software that you
Yeah,
use?
it's commercially available in Japan, and they are now preparing for selling it to abroad. But now still inside the domestic software.
What's the name of this software?
That's the name of software is Grid. Grid and the Grid. I think the company selling it is Compass.
Okay, so but
Compass,
it is
it's
not
done.
available outside Japan.
For the moment, no.
Okay,
No.
wonderful.
Thank you very much.
Thank you, Dr. Shin.
Thank you.
Very nice lecture. We'll call upon Dr. Vijay Parihar to speak on the decade of experience with exoscope. Just an announcement, we are also preponing as per our organizing committees. Request the next two session speakers are also being included in this session. Dr. Abhay Kulkarni is there. Dr. Abhay Kulkarni and Dr. Pravaraj. We have only two more lectures before going for the valedictory.
Okay, so good afternoon and respected chairperson, seniors. Thank you, Neurological Society of India, Dr. Bansal sir, for giving me the opportunity. As Professor Sen has already been said that the future will be on the exoscope and the endoscope. So we are lucky that we have learned microscope also, and now we are learning the future technology also. So microscope is still one of the most important device in the neurosurgical OR because it's high precision device, 3D perception, adjustable focal length, high magnification and illumination. But an ability to look around the corners and surgery and the longer surgery, the surgeon's fatigue and decreased concentration will lead to the development of these hybrid tools like exoscope and endoscope, where you want to sit comfortably and operate while looking at the monitors. So there are challenges with the microscope, especially with the keyhole surgery. There are extreme narrow working angle. You require frequent adjustment of the microscope as well as the table. And in higher focus length, there is a decreased depth of illumination and blind spots are there. Ergonomically, it has been seen that in longer surgery, especially in the posterior fossa or final region surgery, it decreases the surgeon's concentration and leads to the surgeon's fatigue. And also the assistant also find to be difficult with the microscope sometimes in long surgery. And if you want to use the endoscope, the switch to the endoscope is difficult with the microscope. So exoscopy is already been rising and the results has been comparable, even superior to in terms of image quality, illumination, magnification. It provides a stable focus and visualization. A better comfort and team involvement is the most important advantage of the exoscope. And if you want to switch to the endoscope, the exoscope setup is ideal enough to switch the endoscopes. A lot has been talking about the ergonomics nowadays. It has been found that half of us has been suffered some form of back pain or neck pain or some kind of musculoskeletal disorder, and 1/3 or 1/4 required some kind of intervention for that. So the ergonomically utilization of these tools is the exoendoscopic neurosurgery concept. We started using exoscopes way back since 2012 and 13 when the 2D exoscope was available. This provides a high quality digital image equivalent to the operating microscope. It based on the familiar principle of microneurosurgery. The focus length is around 250 to 650 millimeter and the magnification is up to 20x, and the most important advantage, it is very compact. It provides easy to set up and very lightweight. So if you compare the exoscope with the endoscope or microscope, you will find that some of the qualities are like a microscope and some of the qualities are like endoscope. So one can use the exoscope in between the train your resident or young neurosurgeons to switch to the neuroendoscopy.
We are using the exoscopes in almost all sorts of the surgery, right from the supratentorial to the infratentorial and from craniovertebral junction to the lumbar spine. We published the first paper in 2016. That is the first published series from the India, where we have been told about 39 cases with the use of exoscope. We have a book chapter in the recent Kannan Ramamurthy, and this is the last year publication with exoscopic supraorbital keyhole approach for the various skull-based lesion, where we have been discussed the 50 cases. And there is one issue of the neurosurgical focus on total based on the exoscope. This is the 2D VTOM setup. You can see a vitromastoid suboccipital craniotomy has been performed, and this is a very low profile kind of scope. You have to just adjust and there has been good ample space between the scope and the targeted area, and you comfortably sit on the table looking at the monitor, and you can see how beautifully panoramic view it has been given of the CP angle area, and you can do the surgery with the standard bimanual technique. That is another surgery in pineal region where it has been found to be very, very useful ergonomically, and this is the standard procedures, and you can see the scope has been attached to the telescope holder, and you have doing the surgery with the looking at the monitor, and better team involvement. All the team has been involved, and as far as the resolution of these 2D exoscope is considered, it is almost equivalent to the any high-end microscope. So we are performing almost all sorts of surgery. This is one of the example of random sphenoidal meningioma. Opening of the dura, and the microsurgical principle has been followed. Devascularization was done. And the debulking was done with the help of the CUSA. And you can start seeing the opposite optic nerve. And then separating it from the ICA. Sorry. And you can see the resolution is almost equivalent to the any microscope. Sorry, I'll skip. And these are the cases of the posterior fossa surgery, which has been, this is one of the case, posterior fossa midline tumor. Principle of microneurosurgery was followed. And you can see the floor of the fourth ventricle, roof of the fourth ventricle, and that is the aqueduct. This is the CP angle. Opening of the dura, drainage of the CSF through the cisterna magna. Debulking was done with the help of CUSA. Good adjustable, stable focus with panoramic view. Sorry, because of the time. This is the pineal region surgery. You comfortably look at the monitor and operate. That is the view of the third ventricle.
So 2D exoscope has got some limitation initially, lack of 3D visualization, loss of visualization in case of significant intraoperative bleeding, and the technical grade of procedure initially it was criticized, but nowadays we can do almost all sorts of the procedures. Now it has come with the 3D exoscope with better magnification and depth perception. We have recently started using the 3D exoscope also. They come with the other modification of this scope. So there has been issues involved with the exoscope also because of the limited long-term data, and the cost of the training is also involved. And it has been also said that excessive dependence of the technology may lead to some ethical issues also. These are the available other exoscopes. This is one of the exoscope recently being developed in India by Professor Cherian. And these are the table which compare the various type of exoscopes which is available, and ample number of literature has been found recently to support the use of exoscope, like its comparability with the microscope, whether it should be used alternative to the microscope or not. These are the various literature available, and we required long term data to compare whether the exoscope really going to replace the microscope. That is my slide that over the years of more than 1,000 surgery, my perception is that exoscope is still not the replacement of the microscope. It has been useful for the beginners to learn the principle of neuroendoscopy. It definitely improved the ergonomics. It has been a potentially minimally invasive tool, very good for field hospital practice, especially the 2D exoscope, and it has got potential to replace the microscope in the futures. So I was found somewhere here, initial peak of stupidity, and then I fall down, and then now I'm starting learning again. Thank you.
So, Dr. Vijay, can you continue your second talk? Please. One question once. Sir, what will you recommend? You are using Whitehome 2D initially.
Yes.
So, what will you recommend, 0 degree or a 90 degree for initial period?
I don't have much experience of the 90 degree, but 0 degree is good for the cranial surgery, and 90 degree they said for the spine surgery. Otherwise, both are almost same.
Sir, actually in 0 degree, the exoscope holding in this camera is like close to your face.
Sometimes it comes with your...
and I think 90 degree will be better. It will be away from face and operating field.
It is.
Thank you.
But to learn the 90 degree has got little longer curve, because you use endoscopes. So exoscope, 0 degree exoscope, just like an endoscope with a shorter set with higher focus length.
Thank you.
So I'll continue my second talk. When ETV is difficult, lesson learned from the challenging endoscopic third ventriculostomy. So basically ETV is not a disease, it's a decision more than a procedure. It has been now well accepted treatment for hydrocephalus, and its safety has been very well established in the experienced hand, and remarkable benefit of the sun independence with calculated risk is popularized the ETV, but there has been a definitive learning curve occurred to acquire this skill, and one has to understand this learning curve for its safe clinical integration, and learning difficulties, complication and its avoidance is the aim of this presentation. So what are the challenges for the beginners? There has been a steep learning curve. One has to be familiar endoscopically the intraventricular anatomy. You needs to be understand the various instruments, endoscopic instruments available for the ETV, and you have to also be aware of the neural and the vascular injury. One need to have training for how to control the bleeding during these kind of procedures,
and one has to have a surgical expertise, supervision, and adequate volume of the cases to learn these, and one has to have adequate institutional resources and the equipments. So any ETV will be simple or any ETV become difficult. You have to be trained, you have to be planned, and you have to be afraid of complications. There has to be a proper case selection, favorable intraoperative, preoperative and intraoperative assessment. Your experience and proper post-operative care will lead to the successful endoscopic third ventriculostomy. Outcome can be assessed not only the making a stoma, there has to be a relief of symptom. If you make a stoma but there has been no relief of symptoms, then your ETV is failed. And if you're not able to make a stoma, this is an unsuccessful ETV. ETV success score, a lot has been talking about. We have Legend also who has devised the ETV success score. It is the best for predictive tool for the counseling. You can select your cases, you can validate your result, you can evaluate the risk. It is good for the children's. And it has been found that original ETV success score is continuous to demonstrate a strong predictive ability. There has to be need of some consideration of the intraoperative finding, especially the prepontine cysternal anatomy. So we have also got a good experience of ETV in our centers. We are doing ETV for all sorts of indication, including congenital or acquired aqueductal stenosis, posterior fossa lesions. ETV and biopsy can be done. Communicating hydrocephalus in selected cases where there has been ballooning of the anterior of the floor of the third ventricle. Even a slit ventricle syndrome, there are literatures are supporting that slit ventricle syndrome can also be treated by ETV. And the literature has also been coming up for IIH and NPH. ETV and tubercular hydrocephalus, probably one of the most vast experience, because in the government setup we have got lot of number of TB, tubercular hydrocephalus with shunt complications. So we usually do the ETV in tubercular meningitis in chronic phases, and the lack of cysternal exudate, chronic symptoms, and long-term anti-tubercular treatment along with the ETV has got a good outcome. So these are our some publication under the guidance of Professor Yadav that we did for the tubercular meningitis and endoscopic third ventriculostomy. As a salvage procedures and failed ETV, failed shunt or recurrent shunt malfunction or infection, one can go for the ETV. We do the ETV in the clot evacuation in IVH, and also in multiloculated hydrocephalus after communication of all the loculi. ETV is possible if done in 10% of cases and make the patient shunt independence of shunt. You need to have a careful MRI inspection before the performing the ETV. See the lateral and third ventricle size and symmetry, the size of the foramen of enlargement, and interthalamic and interhypothalamic additions, the floor of the third ventricle, the thickness and its bowing, prepontine cysternal vascular anatomy, membrane, and the relation with the basilar artery. And there has to be some kind of idea about the patent distal CSF pathway, which can be assessed by the lumbar or ventricular outflow resistance. Preoperative MRI downward bulge of the floor will enhance the chances and success of the ETV. And if you assess the post-operative scan, the third ventricle changes preceded that decrease as compared to the lateral ventricle size. As I said that in slit ventricle syndrome, the reversal of upward ballooning and third ventricle floor in the slit ventricle syndrome after the lumbar puncture is a good candidate for the ETB. Good CSF flow in the basal cistern alone does not ensure that ETV succeed, and further patent CSF pathway is also required. Intraoperative point has to be taken care. You need to put a proper burr hole site in axial, coronal, and sagittal sutures. Burr hole we generally made on the right side in symmetrical enlargement, but on the smaller ventricular size in case of asymmetrical enlargement to easy perforation of the septum pellucidum. A wrong trajectory can lead to the damage to the other important structures. This is one of the video of the ETV and biopsy.
One can do with the two trajectory or one can do with the one trajectory, but be careful about the contusion of the brain. This is the posterior third ventricle lesion. We do perforate with the blunt perforation with low bipolar setting. And then we dilate with the third ventricular ostrum forceps. After that, we turn the endoscope to 180 degree to get few millimeter extra margin towards the posterior third ventricle side, and this is the lesion. And then the biopsy has been taken. And the biopsy has been turned out to be a low-grade glioma, and I think that is one surgery that has been. One has to be careful while doing the floor puncture. There has to be interhypothalamic adhesions. There may be large or smaller interhypothalamic adhesion which completely obscure the floor of the third ventricle. In such cases, usually the shunt is advised. ETV in posterior fossa tumor is considered to be difficult because of the compressed prepontine space. In such cases, we usually do the dorsum celli fenestration, and once the third ventricle floor is punctured and CSF is enter, then further dilatation can be done. This is one of the case in the live surgery. This is a solid cystic lesion, and you can see a very low, very compressed prepontine cistern. A very limited space, so we have perforated the dorsum celli. As we perforated, we just find that the basilar is bulging out through that perforation. You can see the basilar is bulging out. Gently try to accommodate the Fogarty, but it is not possible. Still there is a second membrane, you can see. So we did the water jet dissection. I tried to break the membrane, but still it has not been there. With a gentle dissection, you can see a small hole in the second membrane now. Ultimately, we are able to achieve the stoma. Your assistance has to be good enough while using the telescope holder. You should support all the time. This is one of the video of ETV in TVM blocked shunt. You can see this is shunt. Opaque third ventricle fold, distorted anatomy. You can see the prepontine scarring. Water jet dissection. Still there is a lot of scarring. So we break the membrane one by one. And combination of water jet dissection. Finally, we are able to achieve the distal patency. Yes, Dr. Vijay? Okay. Yeah. I'll conclude. So there are various signs are available and various methods to conclude the confirm the patent stoma. We have a good paper from Professor Yadav to complication avoidance. So my conclusion that learning curve that improves with the experience. One should start with the simple and progress to the more complex cases. Small foramen of Monro, narrow third ventricle, large interthalamic or interhypothalamic addition, small prepontine system, post-infective and post-hemorrhagic hydrocephalus should be taken very care of and mind while doing the ETV. One should aware of proximal blind spot, and the repeated performance improves the ability. Thank you.
Thank you. Thank you, Dr. Vijay. Back to back. For want of time, we have the discussion later. Dr. Abhay is there? Dr. Abhay? Yeah. So, invite Dr. Abhay to speak on the ETV success score.
Okay, thank you very much. So I wanted to talk just a little update on the ETV success score. So we had published this, of course, in 2009, and most are familiar with it. And in that time, we've had a lot of use of it and learned a bit about some of its strengths and some of its limitations as well. And I just wanted to, sorry. Okay. Hold on, something was funny here. Let me show and try again. Okay. So I just wanted to start by taking back and reminding how the ETV success score was developed. So this was based on a group of just over 600 patients who were all 19 years old or under from 12 pediatric institutions across Canada, Israel, and the United Kingdom. And also keep in mind that the surgeries were done between 1989 and 2006, although the vast majority were between 1995 and 2006. So we're talking about surgeries that were done 20 to 30 years ago. And we measured ETV success at 6 months' time, and it was based in the statistical modeling that we used was logistic regression. And that's all pretty standard stuff, but just keep that in your mind as we talk about, ways that we can think about improving it. So we ended up with this score, which again gives you a score from 0 to 50 based on the age of the patient, 0 to 30 based on the etiology of the patient, and 0 or 10 based on the presence of a previous shunt. You add those together and you get a score from 0 to 90 that gives the approximate percentage chance of ETV success. So a 5-year-old with aqueductal stenosis and no previous shunt would have a score of 80 or 80% chance of success, whereas a 2-month-old with post-infectious hydrocephalus would have only about a 20% chance of success. And that initial paper showed what we call the internal validation of it. So from that 600 patient cohort, we subdivided it and showed that we developed the model in about 2/3 of it and then verified the model, internally validated it in the remaining third. We then compared it to other published series in the literature that had nothing to do with us to show if there was some external validity to it as well. And so here you can see these are all several other papers from the literature, and we looked here on the x-axis of what the actual ETV success was for those papers, and on the y-axis what the predicted ETV success score was. And you can see if it was perfect, all these dots would have fallen along the dotted line here. Of course, they don't, but there's a strong correlation. And if you look at the 322 patients that were represented in these papers, the actual overall ETV success was 59%, and the ETV success score would have predicted 58%. So really quite good. And then we saw work earlier today as well that showed further evidence of some of that external validation of the ETV success score. But, now that we're quite a while away from the development of the ETV success score, we obviously think about ways, can it be improved? And so some of the ways that we've thought about over the years are could the addition of intraoperative factors instead of just preoperative factors help? And of course, the decision not to use intraoperative factors was intentional because we wanted the ETV success score to be a preoperative counseling tool for the surgeon and the family. But could you have a component with intraoperative factors that would add predictive value? What about the addition of imaging factors, right? I think we all have a sense of the types of imaging factors that might predict success, and what if we add those to the ETV success score? Would they help the prediction? And then now with newer modeling techniques, so we use logistic regression, which was and remains still a good standard statistical technique, but what about modern machine learning algorithms? Could they help the prediction? So we looked at each of these in 3 different studies, and I'll begin by showing the intraoperative factors. So all the work I'm going to show you was done through the Hydrocephalus Clinical Research Network, which I talked briefly about yesterday as well. These are 14 centers across North America that participate in collaborative hydrocephalus research. So for this particular study, this was a prospective study of endoscopic third ventriculostomy in children, 336 patients, where immediately after the surgery, the surgeons would note down various intraoperative findings. Okay, and I've listed some of them here. Whether they could get a good, clear view of the naked basilar artery so that it was clear of all membranes, how big they estimated the size of the fenestration or the ostomy was, whether there was residual prepontine membranes that remained that they couldn't open, was there ballooning up of the third ventricle floor after they created the opening, was there bleeding and how much bleeding was there? We quantified that. And did they do a concurrent biopsy at the time of the ETV? And so we looked at each of these factors to see if they predicted ETV success. And on univariate analysis, we found that the ETV success score was, of course, a significant variable, which is refreshing to hear, but it was a significant variable. But as well, the presence of being able to see a naked basilar artery clear of membranes, that was a positive factor for success, as was a larger fenestration. So a larger hole in the floor of the third ventricle seemed to be associated with greater chance of success, which was not unexpected, I suppose, but good to hear. What was not significant are all the other factors that I mentioned, the residual membranes, the ballooning of the third ventricle floor, the presence of bleeding, or whether a concurrent biopsy was done. However, so we took those 3 factors that were significant on univariate analysis and put them through multivariate analysis. So put them all together to see if they were independent factors. And in fact, the only factor that remained significant was ETV success score. So both naked basilar artery and larger fenestration were no longer significant factors. So, the easy interpretation of this is that intraoperative factors did not improve the prediction of ETV success score. And while that is literally true in this analysis, I think, one has to believe that there's probably a limitation of, even though it was over 300 patients, probably a limitation of small sample size. And if we had a larger sample, we might have been able to show some of the significance here of intraoperative factors in addition to the preoperative factors. But it does remind us here that no matter what, patient selection still is the most important technical factor in doing ETV. All right, what about imaging factors? Can they help the ETV success score predict better? So we looked at a number of imaging factors here. We looked at ventricle size measured by the frontal-occipital horn ratio. We looked at the width of the third ventricle, the configuration of the floor of the third ventricle, whether it was bowed down or not, the thickness of the floor of the third ventricle, and what's called the third ventricle morphology index, which is sort of an index of how ballooned out that third ventricle is. We also looked at here, you can see panel A, B, C, and D representing various degrees of presence of prepontine scarring, and ranging from fairly mild to more severe. And we looked at these as well as whether they predicted. And when we looked at all of these factors, in fact, none of them were really significant except for the presence of prepontine scarring. And we've seen this in a number of other studies, particularly as it relates to ETV CPC, but here now for ETV alone, we're seeing the same thing, that the presence of preoperative scarring made a difference. So you can see here that if there was no prepontine scarring, or if there was just few prepontine adhesions, those patients did uniformly quite well, whereas if there was many prepontine adhesions, those patients did very poorly, not surprising. That was significant as a standalone variable, but again, when we put it into the ETV success score and then tried to see whether it improved prediction, it did not improve prediction of the ETV success score. But again, I'll go back to what I said for the previous factor, probably a result of small sample size, because this does look to be an important prediction factor. And then finally, machine learning algorithms, can they help the ETV success score? So this was work that one of my graduate students who's a neurosurgery resident helped me with. And this was a study of over 750 patients who had ETV. We looked at a number of factors as we would expect from the classic ETV success score, but then we didn't run it just through logistic regression, which is how we did the original ETV success score, but we also ran it through various machine learning algorithms that I've listed here, which are fairly standard ways of looking at it. And these are the results of that. So when we looked at, here's logistic regression, and here are the 4 machine learning algorithms that we used. When we just looked at the ETV success score itself, we could see that the logistic regression, again, actually remained better than everything else, than the machine learning. And when we just wanted to see whether the addition of some of the other imaging factors made a difference. And when we added third ventricular width and frontal occipital horn ratio, which is ventricle size, it was still the same thing. The logistic regression was at least as good, if not better, than the machine learning algorithm. So this suggested, again, that the machine learning algorithms did not improve the prediction of ETV success score compared to the logistic regression models that we'd used in the past. Here again, there's caveats with this, and again, sample size is an issue. Over 700 patients, so these aren't really small samples, but I think that still is a factor in the fact that we didn't show significance with this. But I think probably the more important factor for this particular analysis is that we pre-specified all these variables quite a bit, and that's probably not probably doesn't highlight the strength of some of these machine learning algorithms, where it's better to really not pre-specify and let the algorithms decide what are the important factors. We didn't do that here, but I think that's something we plan to do with a larger sample size and see what they show. So in conclusion, attempts to improve the ETV success score so far have not succeeded. We have not shown that intraoperative factors, the addition of imaging factors, or machine learning algorithms help. That all comes with significant caveats, though, as I mentioned. I don't think it's fair to say that these will not help. I think it's fair to say that the intraoperative factors and preponderant lesions are likely important prediction factors, but we just need larger sample size to show it. I think it does say the fact that you do need a very large sample size to show that there is some improvement. It does suggest that whatever improvement in prediction you're going to get is going to be small. It's not going to be huge, but it may help to some degree. And with that, I will thank you. Thank you.
Thank you.
Any questions?
Okay. So can I request
yes.
Last speaker? Thank you.
Thank you.
Dr. Ramesh, talking on flexible neuroendoscopy for hydrocephalus.
It's not moving. Pendrive videos are not loading. My last presentation.
In the waiting time, any questions for the previous speakers? One or two questions we can have. Yes, Dr. Subodh. Dr. Abhay, question for you.
So, we have always taken ETV success as a surgical success. So, do we have anything on developmental outcomes added to this? Because that would be the real,
Yeah, no, I think so. Absolutely. I think what's far more important than surgical success is the developmental success and trajectory of these children. So we've done some studies that have looked at, have tried to compare that, both long-term developmental outcome and quality of life as the children grow older. The short summary of the various studies that we've done is that we haven't seen a difference between ETV and shunt, because that's usually the comparison. You know, does the fact that you've got larger ventricles over time, does that make your quality of life worse or your developmental outcome worse as well, versus the shunts and you know, potentially multiple repeated shunt obstructions, does that negatively impact? And ultimately, it seems like it's a wash, that both are about similar. But none of those were randomized studies. None of them were sort of prospective. Well, we have one prospective study, but none of them were randomized. The study I talked about yesterday, even though it's ETV CPC, I think we will still get those types of results. So even though the primary results of that will be 1 year outcome, we're going to continue to follow them to school age, so 5 years. And then we'll have very good developmental outcome, quality of life outcome, plus surgical outcome for those. My feeling is it probably won't show a difference, but we'll see. So far, the studies haven't shown a difference.
Yes, Dr. Karmakar.
Very nice update. Thank you, sir. Just a follow-up. We have data for 6 months when we call an ETV successful. What about beyond that? Because it's not always 6 months. You have these patients who grow up and things change with the hydrocephalus. So what about that data? Do we have some data on that?
Yeah, so we don't, and we chose 6 months intentionally because, you know, 3 months would be too soon because we do see some failures, but as we know, the failures are highest early on and they become less and less and less. So there's diminishing returns as you go to 1 year, 2 years, 5 years. Yes, they still do fail occasionally later on, but the extra number that fail beyond 6 months is small. So that's why we chose 6 months. It was sort of a compromise where we would catch, you know, over 90% of the failures. Not all of them, but 90% of them. Yeah.
Yes, Dr. Samir.
Thank you for the update, Abhay. So when you counsel the parents currently in your practice, again, we'll go back to the question from yesterday. If the baby had fetal surgery for spina bifida and you underwent and you performed a CPC you trust, let's say over 90%, how do you counsel them about the success score?
So yeah, that was to your question yesterday, which I didn't directly answer because you asked about the CPC component of it. So I use the HCRN data that J. Reva Cameron published on success rates for that particular group, where it's ETV, CPC, and we have spina bifida data. We haven't, to your point, because I know your next question will be dividing between prenatal versus the postnatal closures and the difference in those. We don't have good data yet on that, but I think that's a very good point because what you've been saying about those, I think, is actually true.
Roughly speaking, CPC that you trust should it add around 10, 15 points?
Exactly. So that's the, if you look at the data, it's actually been remarkably consistent that studies that where we have good quality studies of ETV CPC, it shows, as you say, about 15% higher than what the ETV success score would have predicted for that patient. Exactly.
Thank you.
Thank you. Yes, Dr. Ramesh, I think.
I apologize for the delay, actually. I should go and back up the system. And coming to our topic, thanks for the time. Role of flexible neuroendoscopy in the management of hydrocephalus. So, as we know, neuroendoscopy has become the standard of care in the management of hydrocephalus, but it has its own limitations when the lesion is not in the inline in the operative field. So, when having a flexible scope in armamentarium will help to achieve the target of CSF diversion. सिस्टम नहीं हो रहा है इसके ऊपर मत लगा तो वही तो बोल रहा हूँ ऐसे most of the videos are scattered over the laptop. That's the reason could not bring it on the online. Now we have to go and back up. Sorry that. So we always divide into communicating and non-communicating. We do neuroendoscopy for obstructive hydrocephalus. As we know, it's a rigid and flexible what we have, and the flexible scope will turn around 180 degrees. So I will just skip the basic standard neuroendoscopy. इधर तो जा रहा है So flexible neuroendoscope was used in various regions, especially in the narrow foramen of Monroe. This was a child presented with a trivial fall where we could see some bleed in bilateral foramen of Monroe. Child had a significant irritability, restlessness, and vomitings. Second day, we repeated a scan which showed there is a minimal increase in hydrocephalus. So we thought we'll wait for another day as there is no significant issues. But when we get a call from the sister saying that child is not reactive, having a sunset sign and AF is bulging, then repeat scan showed increase in hydrocephalus. So we are taken up for surgery because for narrow foramen of Monroe there is no ventricular dilatation. We have kept the rigid endoscope at the level of foramen of Monroe and done the ETV using the flexible neuroendoscope. And for lack of time, we'll just move on with the video. And child improved without requiring a shunt. And especially in aqueductoplasty, this case was a triventricular hydrocephalus with a normal fourth ventricle. Regular ETV was done, but reaching the aqueduct was very difficult to get the aqueductoplasty. So having a flexible scope, you can see how much it can turn. It can turn around below, go inferiorly, posteriorly. So the aqueductoplasty was achieved along with the standard ETV. Having flexible endoscope, the natural pathway could also be re-established. So the chances of ETV occlusion can be decreased. Especially in this case, child presented with vomitings and delayed milestones, where it showed a dilated fourth ventricle. Our neuroradiologist was enthusiastic and he was repeatedly telling me it's obstructive hydrocephalus than a third communicating. So we took for a standard ETV followed by we took a flexible neuroendoscope because aqueduct was open. We gradually using a flexible neuroendoscope passed through the trans aqueduct, reaching the floor of the fourth ventricle, and the membrane was so slowly the membrane was opened and dilated with the stroma. This is an old video. I'll just show this is a second case of transaqueductal where the fourth ventricle is also dilated, where standard ETV was done, and using flexible endoscope, aqueduct was gradually navigated through the flexible scope was gradually navigated through the aqueduct, reaching the fourth ventricle. The membrane was very tough. Using the flexible monopolar, we can perforate and gradually dilate to number Fogarty, and we can even see the vessels inside, as it was nicely pulsating in the naked vessels. We thought and luckily child is after follow up after 4 years now and not requiring a CSF diversion. So transaqueductal, when in a safe hands, when we can navigate and you have every instrument, it can really helpful. This is a Galaxy type 3 arachnoid cyst, where cyst was very tough. Used a knife to incise, then took the flexible scope to complete a cystonostomy, so that and see the naked vessels whether there was any cystocystonostomy was complete. So flexible scope can use to do cystocystonostomy, especially in tough situations like arachnoid cyst. In this case of multiloculated hydrocephalus, this is a child for which hydrocephalus, outside they have done a shunt. They presented with irritability, restlessness, and identified as some shunt infection, managed conservatively. Now child presented with some abnormal movement, what we call as bobble head doll movement. So when we did a scan, it showed a multiple loculations. So using a navigation and a flexible scope, all the loculations were perforated and then shunt. There's only single localization. Now child complete loss of bobble doll syndrome movements, and also child is achieving milestones. This is a second case recently did with bobble doll head movement with a multiloculated hydrocephalus, which using a flexible scope we could navigate all the loculations, and the child now is improving and achieving milestones. Especially in difficult third ventricular flow, along with Dr. Bodh sir, we have done this study at Kamneni, that using a ETV translaminar and interlaminar terminalis, especially above the optic chiasm, having a flexible scope will help to open the laminar terminalis, and we have published way back in 2016. This was our thank you.
Thank you, Dr. Ramesh. Thank you. Well finished well in time. One quick question to Dr. Ramesh. So with that, we'll wind up. Thank you. We thank all the speakers for the session, and I think we could finish this program much ahead. And over to Dr. Organizers for the Dr. Menzel is there? I think we conclude the scientific session for this conference. Thank you very much.
Request everyone to remain seated because we shortly starting with the valedictory. So please.
मैंने बोला था पहले. Thank you very much, all dear friends, for being here to attend this NEUROENDCON 2026. We are glad to be
see you all from across the globe. My friend Samir from US and Japanese and my Indian close friends like Vikram, Subodh, Sumit, they all have to come and they had come. So I'm very happy that this conference was successful, as everybody is saying, and the talks were very informative. Now we have come to the conclusion of this year's meeting, and this is the time to distribute the awards. I would invite first our president, he's just coming, and by the time I would invite the secretary also, Dr. Sumit Sinha, by the time he should come up. And Subodh also for the award ceremony. Okay. If our friends, if has anybody anything to say, please, how to improve things we can do. If you have somebody can speak something, come on please. So, first of all, congratulations to Dr. Bansal and the organizing committee of the NEUROENDCON 2026. It was a great success, full of excellent science, entertainment from last night. I think it was a special night, and building on new friendships. So congratulations again for a very successful meeting. On behalf of the invited faculty from outside of India, this will be a very memorable meeting. So thank you again. Congrats. Dr. Abhay can say some few words of thanks.
So I want to thank Dr. Bansal very much. What a wonderful meeting, what a wonderful hospitality, and it was again fantastic to see the quality of the presentations, the engagement of everybody, and just the warmth that was present here. So I always enjoy coming to this meeting, and my deepest thanks for having me here and for organizing this wonderful meeting. Thank you.
Thank you for being here all the way in this bad time where the war is going on, in between the one part of the world to the other part, in between the war is going on. Still you were there to come on the way. So we are highly grateful to you. So now this is the time to give awards. And first of all, I would invite our President of the Society, Professor P. Sarat Chandra, on the dais, and then Secretary, Dr. Sumit, and the President-elect, or the Vice President, Subodh. Now, after a few minutes, he will be advancing. उसको डरना चाहिए भाई वामसी वसुंधरा कुछ भी है दोनों में से anybody from there is good कोई है क्या आशीष अवार्ड की स्लाइड से Anybody from NIMS here? Hyderabad? This is the top three podium presentation award papers from the residents. The third, I would invite Dr. Saras to receive trophy from the President and the Secretary. Dr. Saras, is he here? No. The second prize goes to Ikraj Singh from PGI Chandigarh. Is he here? No, he's also not here. So the first prize is to Dr. Meghna. She's also from PGI Chandigarh. She's also not here. Okay. No. No. If the people are not present, the cash prize goes to the organizing secretary. the winner will receive the certificate. So the next
the quiz results. The third prize goes to A team in the quiz, which happened yesterday. The A team consisted of Himanshu Prasad and Kshitij Raj Mahajan. Any one of them here? The second prize goes to team B, Sumit Vargaonkar and Shubham Gupta. Anyone here? Anyone from SMS? Shubham? No. The first prize goes to team C, Machawarapu, Mahesh and Kevin Sudevan. Okay, good. Now the next is the e-poster prize. The third prize goes to Manish Rawal. Is he here? Yeah, coming. He's from MIMER Medical College, Pune. He is, you would be surprised to know, he is a medical student. And we should be inspired from him that he is not even completed his medical graduation. And he presented his poster. He requested me many times that he wants to come to attend the conference, then he wants to present the poster. And every time I encouraged him. And he said that we are students, we cannot pay so much of money. I said, what amount you want to pay? You should pay at least some amount, so you should come. He said that I can pay 3,000. Okay, come. So the money is not important. The enthusiasm and the inspiration, which is more important for me, that what I project. The second prize goes to Shri Chitra Abhishek Latish. And the first prize goes to JSS Medical College student MD Krishna Narayan. Congratulations to all the winners. Now the time is to hand over the leadership. So I would request to Dr. Professor P. Sharchandra to say a few words and hand over the garland to Dr. Subodh, who is the upcoming president.
So at the outset, I would like to congratulate Dr. Bansal for putting in so much of pain to organize this very nice and exemplary conference. Now, my sense of gratitude to all the faculty, especially those who have come from outside the country, very long distances, which is not easy in today's world with so much of war and strife. And you have been sitting here till the last day, so that's a word of appreciation from all of us. And my appreciation to all the delegates who are still here. Despite this being late Saturday, by this time, most of the people would go. And of course, to all the leaders of the society who have taken part equally. So it's with pleasure that I will hand it over to Dr. Subodh. So Dr. Subodh at one time was my student. And it's not always a common thing that the presidential battalion is passed from a teacher to a student. It's usually, so this shows that our generation is changing. We prefer younger people and more, dynamic people. And for me, I think
the biggest stress was keeping this for 1 year. You know, I had misplaced it about 3 or 4 times. Then I was really asked my secretary, then I changed my room, I asked my secretary, and we had to search for 2 days to find it. And they were very upset when I didn't wear it for the oration. So with pleasure, I'm going to give this to Dr. Subodh.
Now this, thank you, sir, Sharif Chandra, sir, to holding the responsibility for a year long. Now he's shrugging from his responsibility, but we think that he will be the part of the society in the future also, and will also look after the society to upgrade our younger generations. So thank you, sir. Thank you. One of our AC member, Prakash Nair, is not here. Subodh, this next year's conference, you all know, we were showing the slides, is given to Hyderabad, and Dr. Vansi Krishna is the organizing chairman, and Vasundhara is the organizing secretary. Unfortunately, both are, I think they are not here, so I'll give this responsibility to Dr. Subodh again, so they lives in the same city, so he can hand over to them. Dr. Subodh will say some closing remarks. Thank you.
Thank you, Bansal. Thank you, NSI, Dr. Sharad, Sumit, Abdesh, Prakash, and all the members and the duty for this responsibility. I think I will carry it on with utmost responsibility. This responsibility I'll carry it. And I welcome you all next year to Hyderabad. I'm part of the organizing thing. So I don't know whether we can maintain this standard what Bansal maintains. So hope to do good things, and you will be having an enjoyable memorable meeting. Thank you again. A big round of applause for Dr. Bansal, please. He told me to mention that, including the dancers also.
Thank you. Now you all are invited for the lunch and spend some time together, and then we'll say goodbye to each other. So safe journey to all of my friends, whosoever, wherever they are going, and have good health so we can see again next year. Thank you all from the depth of my heart. Thank you very much.